And here you can see how sinuses are so strategically located in close proximity to the orbit and the skull base. You know, the margin of safety in sinus disease is so less. You have to be very accurate. Even you have to respect the sub-millimetric distances so that you don't get disoriented and give complications. And in order to do that, you need to have a good three-dimensional dynamic imaging, because certain structures are best seen in certain cuts. Axial, coronal, sagittal together give complete information. And to this, the dynamic information helps you relating each other in all planes. It's not about getting CT scan done simply. It's about fine sections, multiplanar CT scan done, and then you can run on your software to see dynamically everything. So this particular patient, we have discussed in the morning about understanding this disease at the molecular level till the concept and decision making, and then various endotypes. So this first case starts with an interesting endotype. This is a case of allergic fungal rhinosinusitis. And what you saw, what we discussed that in the afternoon, allergic fungal sinusitis present distinctly with certain classical features on radiology as well. Can you see something?
Yes, sir.
Heterogeneous hyperdensities, wide ballooning of the sinuses. Disease is trying to push the sinuses out towards the perisinus area, and this is how this kind of the disease presents. See this fungal eosinophilic material which is presenting as hyper and hypodensities. I hope I am audible.
Yes, sir. Audible, sir.
So this patient as a classical, see, this has all the classical signs and symptoms of allergic fungal sinusitis. This is an endotype. If you remember, we discussed with a classical presentation. These patients are allergic to fungus. This patient has a high IgE as well. Classical unilateral disease, classical heterogeneous hyperdensities, and the treatment. Now coming to the treatment, it involves, see this, full house sinus surgery on this side. Full house sinus surgery on this side, removing all this antigen and eosinophilic material, and to give wide openings for the future surveillance and future topical steroid irrigations. That is the goal of the surgery. So we have to address all these sinuses unilaterally. We will respect not to go to the opposite side as we discussed, to give disease to the opposite side. So CT scan has a role in confirming your diagnosis. Now anatomical details. What we expect from the CT scan is to give us three-dimensional information about the anatomy of the patient dynamically. See this, in a dynamic manner, I have reconstructed to all planes. If I take my cursor here, you can see the frontal sinus in all planes, and this is the sail behind the frontal sinus. See, in anteriorly, this is the frontal sinus. Behind the frontal sinus come, if I go, see this is most anterior. Looks like multiple septations, but as you go behind, see this, these were incomplete septations giving the picture of scallopings. And now this is true intersinus septum, and these are the two frontal sinuses, pneumatizations in the frontal bone. And what we see here, the left is opacified and right side is absolutely clear. Now, as we, from here, as we go behind, until now, this is the beak. See, this is frontal sinus anteriorly. This is the floor is formed by the beak. Now, when we are coming from anterior to posterior, where the beak ends is the beginning of the frontal sinus drainage. So now we are going behind. See, the beak is intact. As long as beak is intact, is the sinus proper, and now is the beginning of the frontal drainage pathway. See how the frontal sinus is draining over here. this classical unilateral, opacity. Now, see now, my frontal sinus was until here. See the beak? See the beak?
Yes.
Now,
Yes, sir.
as I go behind, now the frontal sinus ends. Okay?
Yes, sir.
Now, this pneumatization going above the orbit, bilaterally going above the orbit, behind the frontal sinus. Now, the frontal sinus is ended. Behind the frontal sinus, this is supraorbital pneumatization. See this? This disease
Yes.
is massively involving the supraorbital cell. And this cell is extending above the orbit. This cell is behind the frontal sinus, just caudal to the frontal sinus and going above the orbit. Now, as we go behind, see now, this is the cribriform plate coming into picture. See the cribriform plate, crista galli, the olfactory fossa. This is supraorbital pneumatization. See this huge pneumatization of the supraorbital system, both sides supraorbital cells. Now see inside the orbit. Wanted to show something inside the orbit with changing the intensity window setting. This is optic nerve. This is medial rector. This is superior oblique. Now, as I go behind, see at the confluence of medial rectus and superior oblique. See here, this is beaking of the orbit. Beaking of the orbit. Beaking of the orbit. Can you see some structure going out?
Yes, sir.
That's the bony canal. That's the bony canal for the anterethmoidal artery.
Anterethmoidal artery, sir.
See how posterior it is. We started, see in the sagittal section, we started here. Here the beak ends. And from the beak, if I refer to this canal here, see from the beak, it is more than a centimeter behind. So you don't need to frighten yourself. See, more than a centimeter behind. Can you see?
Yes, sir.
When you work with a 70 degree in the frontal sinus, don't worry about the anterethmoidal artery damage. It is far behind. See, I'm coming back anteriorly. I'm coming back anteriorly. That's the frontal sinus. Now I'm going behind frontal recess start, supraorbital cell start, going behind, and now the anterethmoidal artery starts. See here how posteriorly it is, and where the anterethmoidal artery is, this is the beaking of the orbit where the artery is living in a bony canal from here to the, see, this is olfactory fossa of the brain. This is the lamina, cribriform lamina, this is medial lamella, this is lateral lamella. Medial lamella, lateral lamella continues with a thick frontal bone. This ethmoidal lateral lamella continues with a thick frontal bone, and this artery perforates the lateral lamella to enter the cribriform plate, the olfactory fossa. Now, from this point, if I go behind, the anterethmoid ends. See now the cribriform ends.
Yes,
And
sir.
the postethmoidal roof starts. That means anterior ethmoidal artery traverses through the posterior most part of the anterior ethmoidal roof. Got my point?
Yes, sir.
Where the artery is, behind that postethmoidal roof starts. See this ballooning of the allergic fungal mucin, pushing the septum to the opposite side. This is all ballooning. It is not perforating. And now as you go behind, see the entire postethmoid is covered. All, see the big cells in the postethmoid, no septation seal, all material, hyperdense material. Now the sphenoid comes. This is the orbital apex on both sides. The sphenoid comes, same hyperdensity continues in the posterior part of the sphenoid, and here behind. These are two sphenoid sinuses. The right one is bigger one. The left is the smaller one. And as you go behind, you see this thick bone separating the optic nerve from the sphenoid sinus. There is no, dehiscence of the optic nerve or carotid artery or anything in the sphenoid sinus. So this is a classical picture of one of the endotype, that is allergic fungal rhinosinusitis in this patient. Correct. And you see, this is what we discuss. Anything, any query about allergic fungal sinusitis, I am not describing the CT scan in detail. We'll be looking at the CT scan before every case, and some or other finding I will keep highlighting. So this is the first case, everything ready, right from the maxillary sinus, frontal sinus, maxillary sinus, ethmoids, classical unilateral allergic fungal sinusitis. Any questions?
Sir, like in sinonasal tumors, like what is a CT scan finding? Like if it is.
Yeah.
Hello?
Yeah, so sinonasal tumors are something which you have to be suspicious. Once you look into the nose, you will find in the inflammatory disease multiple polyps. In this patient, like you will see the fungal mucin in between and classical symptoms of allergic fungal sinusitis rules out any tumor. Yes, once you suspect any tumor with something suspicious, not looking polyp, some symptoms not warranting like polyp, then you have to be, ordering further investigation, contrast studies, all that is required in those situations. Routinely, it is not required. Hello. Hello.
Yes, sir.
So, do we go ahead with the surgical part or any
Sure, sir.
questions regarding this?
Sir,
Yes.
is this software available easily? Like we can see all the three planes in one go.
Yeah, this is
We-
available at Google.
Okay.
You can download from the Google.
What name, sir?
Huh?
Any
Name
name?
is Radiant Dicom Viewer.
Radiant Dicom.
Radiant Dicom Viewer.
Thank you, sir.
You can download, you can use it free for some time, and there is some nominal price for the lifetime. You can subscribe it.
Thank you, sir.
But this is very versatile, or any DICOM file it can open, and this is really good to have dynamic imaging. Okay. Work. So now we are switching to the surgical part. There are endoscopic picture lagana. As we discussed, I hope I am audible.
Yes, sir.
So as we discussed, the pre-operative preparation is very, very important before surgery. And this has to be started few days or weeks before surgery. Are you getting the endoscopic picture?
Yes, sir.
Can you see the allergic mucin?
Yes, sir.
The
Well seen,
classical allergic mucin I was sucking out. See this? Hello?
Yes, sir.
Yes, sir.
Visible, sir.
Yes, sir.
Classical allergic mucin and multiple polyps. See how these patients present. This is classical, one of the endotype, allergic fungal rhinosinusitis. Okay?
Yes, sir.
See the allergic mucin. Now the pre-operative preparation, I told you the aim of the preparation is to optimize surgical field. And see what I'm using here, intraoperative preparation. Until now, no preparation was done, and I'm using saline adrenaline here in the ratio of 1:2 and carrying through the marrow cell. See, two marrow cells cut in different size pieces, soaked in the saline adrenaline solution and applying in the nasal cavity softly, not very hard push. We are not supposed to press into the cavity to give venous congestion. Just apply adrenaline on the mucosal surface. Okay.
Sir, one part of saline and two part of ADR, or
Yeah. So there is nothing hard and fast. In young patient, you can use even pure one.
one is two?
But this is topical. We never advocate infiltration into the nasal cavity. Any adrenaline, if you infiltrate, happens to go in the systemic circulation, can have, fatal cardiovascular effects. So it should be as much as possible avoided. And what we believe, if you do a proper pre-operative preparation and intraoperative preparation, you ultimately achieve the same quality surgical field, even without the infiltration. So here I am doing topical one. See, the aim of the topical is to apply adrenaline to the mucosal surface everywhere to decongest it. And even the single application of the adrenaline prevents its further absorption. And you really don't need to, use the adrenaline again and, infiltrate the adrenaline again and again. Say this preparation, I am decongesting the mucosa, nothing else, just decongesting. You don't need to keep the pack for long. You just apply for few seconds, remove it. The beauty of the marrow cell is it is so atraumatic. Rather than gauze pieces, it is so atraumatic to the mucosa. The mucociliary activity remains unaffected. It is not damaged with the material. See this all eosinophilic mucin.
Yes, sir.
See, these are multiple polyps, eosinophilic mucin, and my
Generally, how much
nasal cavity. Yes.
Sir, how much time it takes to decongest? Generally 10, 15 minutes or what?
Yeah, 5 to 10 minutes. You don't actually, you apply for 1 minute, apply for 10 minutes, the effect is going to be same. Our goal is to apply this on the mucosal surface, not anywhere. Now, this is one part, the intraoperative preparation. Other part of the intraoperative preparation is to reduce the cardiac output with the anesthetist's help. And our anesthesiologist here, whom with I'm working, is an integral part of our team, and I have done more than 1 lakh cases with him in our otolaryngology head and neck skull base surgery. He has been part of our, entire team here for so many years, and he gives us amazing field by means of reducing the cardiac output. We never ask for, hypotensive anesthesia or anything which could be detrimental to the patient's cardiac status, particularly in, cardiovascular labile patients having coronary obstruction or anything wherein hypotensive tension can precipitate a cardiac event. We never ask for that. And this bleeding particularly, to understand, is basically not from major arteries. This is purely from the capillaries. And here the most important parameter which minimizes the bleeding is the reducing the cardiac output. And that is achieved best by reducing the heart rate. That's it. You don't need to give a hypotensive anesthesia or do anything. See now, polyps have shrunken.
Yes, sir.
Nasal cavity has opened up. We have
Yes, sir,
to be
well said.
strict, not going to the opposite side straight. How is the picture there?
It's perfectly fine, sir.
Hello?
It's fine, sir. Perfectly fine, sir.
Hello? Hydrodifferent.
Picture is clear, sir.
How is
Picture
the
is
picture
clear.
there, sir?
Picture is clear, sir.
Okay, so now what I am doing, I'm using the micro divider here to remove these luminal polyps. To open up the nasal space. See this polyp and insipid fungal material. I don't see any anatomy beyond the polyps yet. So I'm trying to remove the luminal polyps first to get more orientation. See this? See this fungal material, the classical cheesy fungal material
Yes,
which
sir.
you see in allergic fungal rhinosinusitis. See this?
Yes, sir.
Yes, sir.
This itself is one of the criteria to establish the diagnosis of allergic fungal sinusitis. What now I have come to see is the middle turbinate. See this?
Yes, yes, sir. I can see, sir.
See this osteomeatal region, because of the massive polyposis and fungal material, gets deformed. See the anatomy here gets deformed.
Yes, sir.
You don't see the regular structures. We'll show in other cases how different it is. Now the uncinate process even is deformed. See this? What we see is this cheesy material, nothing else.
Yes, sir.
This is all cheesy material, fungal material with polyp. Like that. And this fungus is so sticky, it frequently clogs your section as well. Uncinate is completely deformed. Middle meatal region is completely deformed. Practically, you don't have, proper landmarks in the lateral wall to identify the regular structures.
Yes, sir.
After every step, see this? Improve your field by, see this is constant saline irrigation. Improve your field by same marrow cell pieces.
Which is the best place to take biopsy for basement membrane thickening and eosinophilia?
Yeah, you can take from any of the polyp or any, good affected mucosa.
Sir, there is a mild deviation.
Yeah,
Like, when do you decide to do septoplasty or?
yes. So once it comes to septoplasty, we need to understand why septoplasty is required most of the time. Most of these cases require some sort of sept or terminoplasty. Because one of the goal of this surgery is to provide good avenue for topical irrigation to reach everywhere. Now, in such situation, it is the nasal septum or the turbinate which sometimes come your way. And you have to address them so that your nasal irrigation should go uninhibited to all the sinuses. That is the goal. So if your septal deviation or anything comes in between, you don't have to think twice. You have to correct this. But if you find, see this space, if you find that your septum or turbinate is not going to obstruct the solution reaching to the sinuses, you don't need to. So that is highly problem oriented. बढ़ा दे. See this cheesy material. I haven't seen the uncinate process clearly. It is all deformed.
Will you send this cheesy material for fungus also?
For academic purpose, you can, but otherwise, it is not going to change your, treatment. See this? For sinus surgery, you need to have a good suction backup. Because such easy material can always block your suction tip any point of time. See, this is so cheesy. Now see, this is the uncinate process which is deformed.
Yes, sir.
See, this is the uncinate which is deformed because of the mass effect in the middle meatus. See, I
Yes,
am
sir.
using, this is your inferior turbinate. Above the level of the inferior turbinate, this is your uncinate process. I am using reverse biting to bite the uncinate through, coming anteriorly until you feel the hard bone of nasolacrimal duct. You have to be very careful in this regard. And see, this way, I am opening the middle meatus, the maxillary sinus ostium, all deformed, all full of disease, no landmark. So what did I use as a landmark? Inferior turbinate staying just above it. Inferior turbinate is the landmark. See, that was the inferior turbinate. I stayed just
Yes, sir.
above it. And see now at this point where I fracture the turbinate posterior part, this is the middle meatus which I am widening now. See, my landmark guide was the inferior turbinate. See, here was the inferior turbinate.
Yes.
Stayed above the inferior turbinate because there was no other landmark. This way you can remove the horizontal part of the uncinate, which is not very clear here. And this is all maxillary sinus, out the motor. All material filling the maxillary sinus. This is I am with a 0 degree, still with a 0 degree. Still with a 0 degree. See this? Hello?
Yes, sir.
Hello,
All this fungal material coming.
sir. Will you use the hydrodebrider at this stage? Would you like to?
100%.
Will it?
100%. Hydrodebrider is reserved for such cases only.
Sir, we are really waiting for you to use it to see how it works.
Yeah, I will show you. I will show you. First, I am removing whatever fungus I can remove with my suction only. This is the high power suction which is required in sinus surgery. This is prerequisite to keep your micro debrider also perfect. Repeated suction blockage, repeated debrider blade blockage ultimately affects the micro debrider. See this? All material. This is so cheesy a material. Without hydro debrider, you can't expect complete, you cannot ensure complete removal. And if you leave the fungus, actually you are leaving the same stimulus which started the disease behind. So let me change to the 70° soon to show you the maxillary sinus better, and then we'll clear the disease from the maxillary sinus. Meantime, again pack. Keep optimizing your surgical field. Yes. Now 70°. So I'll change to 70° and show you what is there in the maxillary sinus. I just widened a little bit, remove part of the fungus. Let me clear this to show you.
Sir, what is the best technique for turbinoplasty as per your experience, sir?
What is the
Best technique for turbinoplasty as per your experience, sir?
Yeah, so there are various techniques for the turbinoplasty depending upon the situation, both for the inferior and the middle turbinate. Whenever in the cases student tomorrow needed, I will show you when which technique is important. That is what I want to tell you, because this middle turbinate often comes in the way, it may become floppy and can block the ethmoidal axis. That is detrimental to the topical solution reaching. See now the maxillary sinus with the 70°.
Yes, sir. Yes, sir. Nice, sir.
See this mucosa, reactionary mucosa because of the fungus. This is pure reactionary mucosa because of the fungus. See, one of the ways to remove the fungus is to catch in the ball prop, twist it, and it comes out. This is very, very frustrating sometimes. But our high power section will not leave it. Out the no motor.
Hello, sir.
Yes, please.
What is your treatment for chronic isolated maxillary sinusitis, like extended What is your approach?
For chronic maxillary sinusitis, depending upon the cause, you have to clear that and ensure that your ventilation drainage is affected. We discussed couple of causes like odontogenic, anatomical related, concha or anything. Isolated sinusitis is either because of fungal disease, some anatomical abnormality. For maxillary is because of one of the big reason is odontogenic. So you have to establish the cause, why it is.
So in this kind of extensive fungal disease, like do you do medial maxillectomy or canine fossa trepanation?
Canine
Do you
fossa is
advise?
required if you have not given adequate widening, adequate, mucosal disease removal. You are not able to access through the regular osteum. If you want, I can show you canine fossa in this case also. That's a good way of, addressing the maxillary sinus from within everywhere.
No, we want to see extended medial maxillectomy.
Extended medial maxillectomy is not indicated in this case, otherwise I would definitely do. In this particular case, medial maxillectomy is not indicated. See the interior of the maxillary sinus.
For maxillary sinus clearance, 70 degrees always required, or sometimes we can
Yeah,
do
it
only
gives-
with 0.
It gives good visualization. 70 degrees for maxillary sinus, reaching out the all area of the maxillary sinus. See now this with the angle telescope angle debrider, and you can reach out so well. There is no comparison to the 70 degree. See this maxillary sinus?
Yes, sir. Very nice.
This picture cannot be seen with a 0 degree like this. With this, we can go and remove the disease from the anteriormost part of the sinus as well. And now I will be mopping the sinuses. I have to ensure the anterior disease removal. If required, or if you want, I can show you the canine fossa also. This is a good example. See, I am mopping and removing the fungus by means of marrow cell mop. See this?
Yes, sir.
This mucosa in vicinity of the fungus is reactionarily edematous. See the interior of the maxillary sinus which was full of disease. Much better.
Yes, sir.
Now what I will do, let me show you canine fossa. Give me a pack. In a minute's time, I can show you canine fossa. Canine fossa, once you think you can do it without any, adverse effect, what you need to do is, see, you have to enter,
Do you use steroid soaked marrow cells for mopping up?
Yes, yes, always. See
Yeah.
this, you have to be in the mid-pupillary plane, where the wall of the maxilla is thinnest, where the anterior wall of the maxilla is thinnest, and a centimeter above the gingival line. See this?
Yes, sir.
Hello?
Yes, sir. Yes, yes, sir.
Yes. And then you are right in the maxillary sinus. See this? I am in the maxillary sinus. This. a centimeter above. Yeah. Now we see from inside, just to see where we are. Yeah. Yeah. Section. Can you see the trocar coming from there?
Yes, sir.
Trocar and cannula coming from there outside. And what we can do, I'll remove both of these. Remove both of these and introduce my debrider directly. So now I have introduced my debrider.
Hello, sir.
Yes.
If the patient refuses for canine fossa trephination, what is the alternative?
Then you have to use your angled instrument and mop and clean. See this fungus.
Okay, sir.
See now, I am using red 40 blade from the canine fossa side. And see all hidden area of the maxillary sinus, particularly anteromedially. See, maxillary sinus has been fully uncovered. See, this is the medial recess of the maxillary sinus.
Can it be done other way around also? Put endoscope from canine fossa and use debrider from this side.
See, once you have a 70-degree, see this, each and every nook and core of the sinus can be seen. See this?
Yes, sir.
360-degree. My blade is somersaulting inside. See everywhere, that's the prominence of the infraorbital nerve.
Very nice, sir.
Now see the maxillary sinus is crystal clear. And now I will use my hydro debrider to wash away every single particle of the fungus from the sinus. See this? This hydro debrider, let me tell you what exactly it is. See this. This is the equipment attached to the IPC. Can you see? This is like a gun and I can rotate it 360-degree. See this, to irrigate sinuses anywhere. Can you see? And it is attached to a pump. See this? See in the maxillary sinus? Can you see? Rotating 360-degree.
Sir, wonderful. Sir, what is the cost involved, sir?
And now I'm using the water jet. See this? High pressure water jet.
Great cleaning, sir.
See this? You cannot leave any fungal material behind. See high pressure water jet.
Yes, sir.
Now let me show you. Give me a mop. Sometimes you know what happens? Due to edematous mucosa, in the mucosal convolutions, you may leave the disease behind. And you have to ensure that no fungus remains behind. What you do? First of all, do mucosal decongestions so such convolutions can be flattened. And then irrigate with the hydrodebrider. Irrigate with the hydrodebrider so that no fungal material, a trace of the fungal material is left behind. This is important because if you leave the material behind, they have memory cell also, they have memory T lymphocytes also that can bring back the same, atmosphere again. So this is the, in our opinion, is the best one. मेरे को दे ये पकड़ छोड़ दे. See the interior of the sinus. See the interior of the sinus.
Great view, sir. Great.
See, all mucosal edema is flattened. All fungus has been cleared off. Sometimes you may
Yes.
not,
Yes.
you may overlook fungus material hidden in the mucosal convolutions and you may leave the disease behind. 0 degree. So what we have achieved is the maxillary sinus clearance. First we achieved the luminal clearance, then the maxillary sinus, and see, we have given such a wide opening. See this? This will help our topical solution reaching there.
This is type 2 magnetostenosis.
Yes, you can say type 2. Type 3 would involve removal of the part of the turbinate to flush it down to the floor of the nose. And type 4 is a sort of medial maxillectomy. Now see, everywhere is this polypoidal disease, fungal disease, no landmarks. See this? Hardly any landmarks. What I see is the middle turbinate here medially. See this? Suction करना नीचे. नीचे suction. See this? This is initial clearance. Now we have to move on to the other sinuses. See, no landmarks. One of the case having good landmarks, I will show one by one all. See, this is ethmoidal disease. See this?
Yes.
And this is beauty of the high power suction.
This is post-ethmoid.
This is beauty of the high power suction.
Central suction.
Now this is the ethmoidal cavity. See, no septation, nothing, no landmarks are seen. It is because of the pressure resorption of septations, looking like a common kind cavity of a situation with minimal landmarks. Now before moving on to the further post-ethmoidal sphenoidal side, now I'll take 70° again and do the frontal sinus work first. And here I will show you I will use a different landmark. In the simplest way, one can never be disoriented to the frontal. Even if you don't have good landmark, still you can reach the frontal without any complication. See this with a 70° now. That is your maxillary sinus. Good.
Yes, sir.
Now with the 70°, se pakadna. Removing marrow cell, looking up, wash.
Can we get the outside picture, how to hold it 70° for frontal?
See now, your frontal opening is not seen at all anywhere. Can you see? Hello?
No.
How to
No,
look
no,
for the
no,
frontal?
Yes, sir. Not see.
There is no landmark to see the frontal sinus. Can you see? What available landmark I
Yeah.
see here is the middle turbinate here. Can you see?
Yes, sir.
Yeah.
And
Yes,
this
sir.
is lamina papracia laterally.
Yes, sir.
These are the two landmarks. Now, I am coming to the level of the axilla. See the axilla there.
Yes, sir.
Yes, sir.
See now, simplest way to reach into the frontal sinus by anybody, any junior colleague without too much of landmarks. See this. This is, see this is lamina papracia.
Yes, sir.
This is your middle turbinate. I am staying between and looking at the roof. That is your beak. See this beak?
Yes, sir.
Yes, sir.
This is the thickest bone. With the 70, this is thickest bone, and where the beak is ending is frontal. This is all frontal. See my lateral, you have to define your lateral and medial limit. Reason being, lateral limit, once you have seen your lamina, you are not going to or not supposed to transgrade further laterally to enter into the orbit. Section. See the beak. Just under the beak is the frontal.
Sir, there is no agarnesia in this.
Not all this. I mean, this disease has broken all.
Okay. Okay, sir.
Wash it. Now, what is it? Oh, hydro. See this material, fungal material,
Okay,
some purulent discharge. What I can do simply, I can go with the hydrodebrider up. See my hydrodebrider? This is the initial clearance. There is a lot of ethmoidal septation there, polyps there. See this? 60. What we have achieved through this, just going. just underneath the beak. Just underneath the beak. इसके लगा के दे रहा हूं. I'm flushing this. There's a lot of material, occupying this sinus. Flush. Section. See more and more frontal sinus getting cleared off. Fetal wall. More and more frontal sinus. Wash. इससे लगा पानी. See now, I've taken a malleable suction inside and going to flush with it. बंद कर. बंद कर. Suction. Suction. This is the big polypoidal lesion. All polypoidal mucosa. This is all fungal material. See the inside of the frontal sinus now.
Yes, sir.
Full of, this disease tissue. I told you, fungus is a direct surgical entity without wasting time on preoperative management. No preoperative treatment is going to cure the fungus.
Sir, what is the landmark here for anterethmoidal artery?
For
Anterethmoidal artery.
that is far off. I told you I am working with the 70-degree far anteriorly toward the beak. Anterethmoid is in different direction behind. I will show you. So this is maxillary frontal sinus from inside. Now see what I am using. Adenoid blade. And see, this is supraorbital recess. I showed on CT scan just caudal to the frontal sinus. This is supraorbital recess. This one, the below. See, this is
Yeah. Yes, sir.
more than one. That is all supraorbital recess. This is all inflammation. See, I am clearing the supraorbital recess.
In the post-op period, is there any special technique to irrigate the frontal sinus?
See, this is supraorbital recess clearance. This one, behind. All this mucosa, thick inflamed mucosa in close proximity to the fungal, because of the ongoing inflammation, is edematous. You don't need to remove unnecessarily and strip the bone. We are not supposed to strip the mucosa and leave the bone bare. See the frontal sinus up. And behind this, this is supraorbital recess. See these convolutions of the sinus mucosa, hypertrophic edematous sinus mucosa, prevents you from assessing any fungal material trapped there. So you have to be very careful not to leave any behind. See the supraorbital area.
Hello, sir. Sir, what is the blade you are using now?
This is 120 degree.
Thank you.
And see, I can see some fungus which is trapped there, still there in the supraorbital recess. See the recess. I am working above the orbit.
Yes, sir.
See the area being opened more and more. I knew from CT scan there's a huge supraorbital cell going about the orbit, and we opened it reverse. See this? This is caudal to the frontal sinus. Frontal sinus is far anteriorly. See the frontal sinus is anteriorly, and this is behind here. Behind here and above the level of the orbit. See that?
Yeah,
The
yes, sir.
supraorbital cell poses challenge. You have to be very careful not to ignore that. This is my reverse blade again.
Sir, like we should be very careful not to injure anterior.
Yes. See, I have opened the
With that-
recess. See the recess I have opened.
Okay.
This is reverse blade. And the entire recess is open now. Completely open. Frontal sinus widened. See, irrigation all the time. And this is your supraorbital. See, this recess is supraorbital. I hope you are oriented.
Yes, sir.
Yes, sir.
And see, still there was a fungus. So you have to be careful in completely removing the fungus from there. See this? See from 70 degree how challenging it. That is supraorbital recess. There's still a sort of fungal ball is there, looks like. Yes, it is. See this?
Yes, sir. Yes.
See this? That was the fungus. I am working above the level of the orbit. Now, once you find a supraorbital cell, your anterethmoidal artery is immediately caudal to it. Immediately caudal to it. See my anterior level of the beak and see how behind I am. I measured there, see from the anterior level of the beak till here. This is complete frontal sinus and the supraorbital cell. See the anterior was the frontal sinus. This is where my suction is. This is supraorbital recess. And frontal is anteriorly. See that?
It's a wonderful visualization of the entire thing. Without the anatomical landmarks, usually we see the identification, you do the identification of the bulla and the suprabular recess. And then you go into these things. Today, there was no landmarks, but still it is so beautiful.
So the disease sometimes, takes away these landmarks. See my supraorbital space is opened up.
Sir,
Everything opened up.
Sir, will you please demonstrate the frontal glow right at this?
Pardon?
Frontal glow, sir. Can we see the frontal
Like
glow right
what?
now?
Frontal glow.
Right, sir.
Now there is hardly anything in the glow. Once you open, once you open, such a big frontal sinus. See that?
Yes, sir. Wonderful, sir.
So the glow is hardly anything. It has to come. Now let me clean this. We have ethmoidal work and posteriorly we have to open up the sphenoid also. But see, the difficulty in the fungus is the location and kind of cheesy material.
Sir, in
See,
these cases, where
maxillary frontal completely clear. There's still a lot of ethmoidal septations left, which I will handle. Lots of ethmoidal. I will again reorient my landmarks in the ethmoids because lamina propria, lamina papyracea is very close.
sir, in these cases where the landmarks are deficient and we cannot see the middle turbinate properly, the lamina papyracea is also obscured by the diseased tissue, bulla cannot be seen. So what is your take on going through a axillary flap or a Caroline's window?
Not really, that is not going to help you additionally. See what is, you have to use one landmark to reach another. Now, see, I am seeing with a 0 degree now.
Right, sir.
And this
We
we
can see the
went into the frontal.
completely.
Using this axilla, where the
Right,
beak
sir.
is, the lamina papyracea and the turbinate.
Right,
Now
sir.
see, I am redefining my lamina. See, my maxillary sinus is here. Using the maxillary sinus, you can reach to the lamina, the medial wall of the orbit easily. See this? I am removing all this to reach.
So this is a type 2 MMA.
Yeah, this is type 2 MMA. Once you enlarge it posteriorly to the level of the posterior wall,
Right, sir. So
I
in
am
all cases of
defining more and more lamina. Now my
okay, sir.
first goal is to define lamina so that I can adequately clear this region. See this? Here all anatomy is distorted. So you have to be using one by one landmarks. Once you see lot of pneumatization of the skull base, anterior skull base, you can expect anterothoidal artery to be prominent. Particularly when you find enlarged supraorbital cell, pneumatized supraorbital cell, anterothoidal artery is likely to be prominent. See this? What I am following is the skull base. Now see what I have discovered. See my level of lamina? I hope very clear.
Yes, sir, very clear.
Now I will define for you the anterothoidal artery very, very clear. Give me 70 again. See, for everybody, there is always a question regarding this vessel. Don't terrify yourself. I had shown you the canal in which this artery leaves the orbit and going to the lateral lamella. See, back
Yes,
with
sir.
a 70-degree. What I have defined here, this is your lamina. Can you see?
Yes, sir.
Reverse. See, I am going to show you that is the caudal border of the supraorbital cell. See the caudal border of the supraorbital cell? We'll use the hydrodebrider later. See the caudal border of the supraorbital cell?
Yes, sir.
See carefully. I am running my blade right over the vessel. Can you see something oblique?
Right, sir.
Can you see the vessel very clear or not?
Absolutely clear, sir.
I will show you. If not, see the vessel.
Sir.
That is the caudal border of the supraorbital cell. See that? Hello?
Right, sir. Right, sir.
Till here is the supraorbital cell and this is the vessel. Very clear.
Where the skull base is bending.
See this vessel? I am just my debrider. See right on the vessel. Can you see?
Yes, sir.
Now, once you've gone behind, you are in the posterior thumoid. Now, I will mop it and show you better. See, that is the vessel.
Right, sir.
Huge inflammation in this case. Huge inflammation. Lot of secondary infection there you saw. Your constant irrigation helps you improving your field. See, this is my maxillary sinus with a 70. That is the maxillary sinus. And
Right.
above is the frontal sinus with supraorbital cell. See, that is the frontal sinus above.
Right.
This is supraorbital cell behind here.
Right.
And this is the vessel, oblique vessel. See this.
Right, sir.
See the vessel very clear.
The bony mesentery is a bit denuded.
Yes, sir.
Pardon?
The bony mesentery is a bit denuded.
Yeah, boy, yeah, partly eroded. See, it is partly eroded here. See this.
Yes.
Can you see?
Right, sir.
Let me remove this little bit of the bone. See the vessel now much better. Hello? I hope it is very clear to
Right.
everybody.
Very clear, sir.
Now give me hydrodebrider. See now the frontal and the supraorbital, so wide opening. Maxillary we have already given wide opening. This is hydrodebrider now. See this inside the frontal. Can you see? Water jet. See the pressure.
Yes, sir. Brilliantly seen, sir.
See the pressure. That is how the sinus has been thoroughly rinsed. Wash this simple. Could you see the jet?
Yes, sir.
Hello.
Yes, sir.
Could you see the jet?
Yes, sir. Yes, sir.
And now see this is. उसमें लगा के देना, कब नहीं है यार. आप लगा दिया? And चल लगा. नहीं जा. Irrigate. Yes. हल्का हल्का. यहाँ घटाने. See the interior of the frontal sinus now.
Right, sir. Looks totally clear. The mucosa can be seen. So what
See the-
solution are you using for irrigation? Is it normal saline or plain water? What is it?
Ringer.
Ringer solution.
Now see the big opening of the frontal and supraorbital. I hope it is very clear. And this is the interethmoidal cell, and now I will go behind. We have done maxillary, we have done frontal, we have done anterethmoid. Now the last work left is the posterior and 0 degree sphenoid. That can be accomplished with a 0 degree. Suction. Funny. Wash. Now we'll first improve the field. See now with 0 degree, your maxillary, frontal, even your anti-ethmoidal vessel you can see very well. See that?
Yes, sir.
Now the last part. Here, since the anatomy is distorted, you have to be careful while going behind. So what I will do, I will not go behind laterally. See laterally, if I go behind, I may not know when I have entered the sphenoid sinus. So what I will do, I will stay medially at the level. See this roof of the maxilla. Stay medially close to the septum. Yes. This was a small sphenoid sinus, if you remember,
Right, sir.
on CT scan. That is the small sphenoid sinus. See, the mucosa is so edematous, hypertrophic because of constant inflammation. This is posterior model work. See the skull base in view.
Right, sir.
In one of the case, we'll show you the entire anatomy in detail, which is not very, extensive disease. 40.
Sir, in these types of cases where the basal lamella, the posterior 1/3 of the middle turbinate, the sagittal section is not properly visible, cannot be made out properly by seeing the anatomical landmarks, there is a chance to injure the posterior ethmoidal artery. So how to be away from that? How to protect the posterior?
Posterior ethmoidal artery generally passes. See, this ethmoidal artery passes at the roof within the skull base.
Right, sir.
Now, post-ethmoidal roof bone is quite thick.
Okay, sir.
So, artery generally is not visible, generally.
Okay, sir.
Anterethmoidal bone thickness is more, so that artery is mostly prominent. See this? All sphenoids and everywhere is bad mucosa. This was the small sphenoid sinus, you can see. That is the intersinus septum which is projecting here on this side.
Okay, sir.
And this is all mucosa, nothing else. So that's the picture. See the final picture.
Sir, if we need to use
That
the
is
debrider in
nasopharynx.
sphenoid sinus.
That is nasopharynx and what?
One question, sir. If we need to use the debrider in sphenoid sinus, what precautions we should take?
Yeah. First of
In
all,
which direction?
yeah, direction should be antero-inferiorly, number one. Little medially directed. Number two, the cutting edge should be in view. Always looking at the anatomy three-dimensionally through the CT scan. Looking at the depth of the sphenoid sinus. If any structure is dehiscent, you have to be careful accordingly. See, this is the picture now. You have to preserve maximum possible mucosa. Maximum possible mucosa. See this? This is thick mucosa. See this?
Yes, sir.
That's the artery. See the artery there?
Yes, sir.
See, the concern is this vessel is it should not be transected laterally to have, retracted into the orbit. That's it, nothing else. Bleeding is never a big issue. See my final
In such
picture.
cases,
I have not done anything opposite side. We discussed we are not going to violate the opposite side. Even if septal deviation or anything, we are not going to do anything now. This is strictly unilateral disease and we have to stick to the same side and don't want to violate the opposite side. Final
One
picture,
question.
that's the maxillary. We have seen the frontal and the supraorbital above. This is anterethmoidal roof. This is postethmoidal and this is sphenoidal. That is the ostium of the maxillary sinus level here and that's the nasopharynx. So this is basically, see, wide openings. This
Very nice
is full house FESS. Full house FESS. See now with a 0 degree, you can see in your OPD and deliver topical secretions, topical solutions. So the goal of this surgery is to give access to the topical secretion solutions. Besides removing this inflammatory load, see this, what a inflammatory load we removed. That would not have been coming under control by any medical treatment. And see this middle terminate, it is close to the septum, it is not going to fall laterally. So nothing more is required to be done. All the sinuses in one view, you can see your topical should reach everywhere, no septum, no turbinate, nothing is coming in between. That was the goal of this surgery. We have to give, since it is allergic fungal sinusitis, give her oral steroid for some days, pack a little, and we will start topicals in 2-3 days. This turbinate is already, lying close to the septum nicely because it was pressed against the septum. The septum is good, not giving any gross deviation. See this? Wide opening of the maxillary, wide opening of all sinuses.
Sir,
We'll
sphenoid
now-
is smaller one in this case.
Pardon?
Sphenoid is small in size. Left side.
What?
No, sphenoid sinus, sir.
Yeah, it was small. I had shown you on CT. Let me show you on CT again. Can you connect? So I have left that. Can you change to the CT scan? Let me show you. Again, CT connect करना. Bye.
Sir, how many ampoules of adrenaline you have used?
Okay. अभी जो लिया वो कहाँ है? उसकी फाइंडिंग. Hello. Yeah, are you getting the CT scan?
Yes, sir.
Hello.
Yes, sir. Yes, sir.
Now see the sphenoid sinus in this case. See, all this was material and see the sphenoid. Can
Very
you see
small,
this?
yes, sir, very small.
Very small sphenoid on this side. See the big sphenoid, what I could see this wall. See where the rostrum is and where the intersinus septum is. Could you see?
Yes.
So this was wide open. This was the supraorbital recess. And I am see this is supraorbital recess now coming anteriorly. And this is frontal sinus.
Yes, sir.
So this was all about this case.
Sir, even the maxillary sinus is also small, sir.
Finding bata kya hai? What?
Maxillary
Hello?
sinus is also small now, sir. Like,
Not very big, reasonably good. See this? Not very big. Almost similar to the opposite side.
So these maxillary sinus, the floor is reaching a bit below the level of the palate. And we have done a type 2 MMA. So will there be a difficulty in the postoperative drainage?
Not really. Still it will drain towards the area we widened, ostium.
Due to
Still it will
mucociliary
drain there. It is not the gravitational drainage which is important. देखा? और उधर
उनकी सीढ़ी तैयार है आप।
हेलो, अभी नेक्स्ट तो वो लेना, वो लास्ट, वो वाला ऊपर। हाँ, आज तो यही होगा। हम्म। Hello.
Yes, sir.
So this was all about allergic fungal rhinosinusitis, the kind of pathology it is. It requires extensive, approach to remove all fungal and mucin material and give wide openings, hydrodebrider to rinse any, fungal particles left over the mucosa, like that. What my point?
Right, sir.
And that is how we could clear this. Now we have a good avenue. We could see with a 0 degree. We will train patient. I will show you tomorrow in the presentation how we train patient to, allow the secretion to go up. So this will go everywhere. That is classical a patient. Okay. Any questions regarding this, please? Can our patient go for next? Hello.
Hello. Sir, how many ampoules of adrenaline you used in this case?
Depending upon 8, 10, 15, depending upon how much you use. But the concentration matters.
The fluid you have used is it hot saline or normal?
No,
temperature?
sir. See, hot saline concept is important for the areas. It is not important for here. Hot saline is important into areas of the skull base where you see the trabecular bone with a lot of venous channel into it, which bleed a lot. And there, hot saline is important in, initiating the coagulation cascade. In the sinonasal area, we rarely, promote the hot saline because it can be detrimental to the mucociliary activity. And it is not required in the sinonasal region. So, never that way. Hot saline is important in skull base, not in the sinonasal region.
Hello.
Hello.
Sir, I have a question. For a sphenoid sinus as small as this one, would a medial approach be safer to open the
Yeah,
sphenoid sinus?
this was a median approach only, but the intersinus septum was far laterally shifted,
Yes, sir.
leaving this sphenoid a small one. So you have to follow the septum and then go behind. In the next case, I will tell you the guide is the septum. Always follow the septum and then, glide into the sphenoid sinus. To enter into the sphenoid, always go gliding along the septum. That is the safest way. Now, coming to this case, the next one. Do we go ahead?
Sir, one question, sir. Sir, post-operative in case of AFRS, should we start, sir, voriconazole or itraconazole?
Not. We have already discussed in the morning. These patients do not require antifungals. These are classically non-invasive fungus. Antifungal is required in invasive fungus, not in these.
Okay,
So
sir.
there is no question regarding the use of the antifungal in these patients. No way. Not needed at all.
So post-operative, what should be management, sir, for medical management?
Yeah. Irrigation dosing after 2-3 days. Oral
Okay,
steroids for a couple of days.
okay,
And then periodical, cleaning, debridement, cleaning the crusting and all that. to improve the steroid effect on the mucosa.
Okay,
Our
sir.
steroid is basically, this juicing is aimed at directing the steroid at the mucosal surface. So the mucosa revert back to normal.
Okay, sir. Sir, the CT sections that you are demonstrating, in all
Mhm.
these, the section thickness is 0.625 millimeter. We are also asking the patient to get 0.625 millimeter. But sir, I always had a question. I don't know why the specific 0.625, why not 0.6, why not 0.5, why not 0.4?
It is somewhere between 0.5, 0.75. See, the idea is you don't miss any important structure.
Right, sir.
More the finer section, the picture will be less, clear. Secondly, with 0.625, you don't miss any structure. The most important structure is the anterothoidal artery, which is roughly 0.8 to 0.9 millimeter in thickness.
Okay, sir.
If suppose I am jumping by 1 millimeter, I can entirely miss the artery. So these sections, 0.5 millimeter, obviously good, but that is not going to add any advantage. So this is somewhere in between,
Okay.
that you don't miss any structure. Simple reason.
Right, sir.
Now coming on to the next one, change karna. Can you make out any diagnosis? Patient has polyps with this CT scan?
CCAD?
Yes. This is classical. So you have seen previously a different endotype, and this is different endotype. And this patient classically presented with olfaction loss. Can you see the olfactory cleft? Hello?
Yes, sir.
Can you see the
Yes, sir.
opacified olfactory cleft completely?
Yes, sir. Yes, sir.
That is classical. The access to the olfactory epithelium, any smell, any air, access to the olfactory epithelium has to be good for the smell. And here, that entire area is obstructed by polypoidal mucosa. Can you see?
Conductive loss.
Yes. I don't know whether conductive or sensory. I have not given a trial of steroid, but yes, could be most likely conductive. And even sometime in the sensory loss, because of this, eosinophilic disease, majority recover once, provided you don't damage that epithelium. What happens sometimes, you have a thick mucosal, this polypoidal disease right in the olfactory recess. You are cleared from below and trying to remove from there. If you try to remove from there, you'll end up giving fibrosis. So don't do anything in the olfactory recess itself, close to the olfactory epithelium. Remove any overhanging polyp or mucosa below that, so that you don't end up giving fibrosis, and then leave it for the steroid treatment and steroid irrigation to return back to normal. If you try to do anything to the olfactory mucosa region by means of removal of the polyp or anything, you will ruin the thing. Number one. Number two, otherwise it generally comes back over the period of time as the this mucosa settles with the steroid irrigation reaching there. That's why we ask the patient to do juicing in particular position. In particular position, that so the solution should reach the olfactory area. Number two, when it doesn't come, is when this eosinophilic disease, eosinophilic cationic proteins damage the olfactory epithelium. That is one thing which can give irreversible damage to the olfactory epithelium. That's why you cannot guarantee your patient that the olfaction is going to come back. But yes, in majority of the patient comes back. If you don't damage the olfactory mucosa region, don't do anything. Even if there is a small polyp, leave it there, so that it doesn't lead to fibrosis there. And rest of the area from below, you can open up for the topicals to reach there. Now see, there is a classic sign in this patient of CCAD. Can you see this middle turbinate?
Yes, sir.
Laterally directed middle turbinate because of the disease coming from medial to it. Can you see?
Yes, sir.
This is classical feature, laterally directed middle turbinate. This is middle turbinate. Middle turbinates are away from the septum, away from their natural position close to the septum. Can you see?
Yes.
And this is the olfactory disease here, main disease. See the main area. Now it has blocked the, see, it spreads laterally to involve other sinuses. Now see, it has spread laterally and blocked the frontal recess. Can you see?
Yes, sir.
And it has given frontal sinusitis. See that?
Yes, sir.
Bilateral frontal sinusitis. Secondly, this is, partially obstructed osteometal region here. See this? And giving the
Yes.
maxillary sinusitis also, more on the right side, less on the left side. Has a septal deviation towards the left. Olfactory fossa. And now most important, a cell. I will show you, I will reconstruct and show you something. First of all, see the cut, size of the cut in this patient. Can you see on the left side below? What
Yes, sir.
size cut?
0.4
millimeter.
0.4. See, by every jump, see my single jump, it moves by 0.4 mm. See this?
Yes, sir.
Now I'll reconstruct to three-dimensional planes and show you some important thing in the frontal, which one can easily overlook again. See, there are certain cells in the frontal sinus region which narrows the frontal outflow from anteriorly. Those are anteriorly attached cells. Okay? There are certain group of cells which are posteriorly attached. And they block the frontal outflow or narrow the frontal outflow from behind. And this is a significant impact intraoperatively while it comes to removal of these cells. Those cells which are anteriorly attached to the beak or anywhere, you can go behind those cells and fracture them anteriorly. But those which are attached behind, you can't afford to do that. Now, in this patient, there is an interesting finding which one can easily overlook and you have to be careful. See this. Let me first show if you can pick up. Try if you can pick up. See, this is frontal sinus. Can you see?
Right, sir.
Sinus proper, intersinus, septal cell, beak. So far, sinus proper.
Right, sir.
Now,
Mm.
what did you see?
Suprabular frontal.
Yes, great. Who is there?
Shoikat, sir.
Oh, Sekat, Dr. Sekat from Kolkata. Wonderful. That is the suprabular or frontobular cell. You know, what is suprabular or frontobular? Those are the cells close to the skull base behind and try to go up into the frontal sinus. And they narrow the frontal drainage from behind. Now see, let me reconstruct and show you. First of all, let me show you this coronal one. How you can pick up from this. See, most anteriorly, no cell in the frontal sinus so far. Can you see? I am going anterior to posterior. There is no cell I can see. Can you see? That means there is no cell attached to the anterior wall. Now I am going behind. See this, the frontal recess started. Frontal recess started. Can you see this cell which is pneumatized? Hello?
Yes, sir.
This is pneumatized cell without any disease, and what it has given? It has narrowed the frontal outflow. See this? See this frontal outflow is here, which is blocked by this cell. Now, where this cell is attached to, look at the sagittal. Look at the sagittal. Can you see this cell?
Yes, sir.
See, the cell is not infected. Cell is not blocked. But see this cell where it is. See this cell, this cell, this cell. Here is the site of the bulla, and this is trying to go inside the frontal sinus. This is frontobular cell. Can you see this?
Yes, sir.
And this is what it has given. It has narrowed the frontal sinus out. Had there been frontal cell, it would have been attached like this. And then you would have to go behind that. Here this cell, see this pneumatized cell attached behind, and this outflow is narrowed anterior to it. Here you cannot afford to go behind that cell, and you have to open up this cell and flush it. I hope it is very clear.
Yes, sir.
Yes, sir.
See how vital is this sagittal cuts. This is a normal cell. Once you open, there is nothing, abnormal inside. This cell is being aerated, but this has blocked the frontal sinus outflow, which has resulted into serious frontal sinusitis. I hope it is very clear.
Yes, sir.
So in this patient, this was another useful finding. Now, after that, another useful finding, let me tell you. Another useful finding. Now we have gone in, this is the cell in the frontal recess. Frontal recess means behind. Far behind. Anteriorly, there was no cell, it is behind. And now is the beginning of the cribriform plate. And can you see on both sides? Can you see both sides the turbinates? Different pictures of both the turbinates. This has a great impact again. See, both the turbinates are pneumatized. Can you see? And see this is the turbinate pneumatized. This is known as concha bullosa. Can you see? And this is full of disease, unaerated. Concha you may find aerated once it is receiving aeration, and this is no ventilation, and see it is inflamed. Can you see? Hello?
Yes, sir.
See on the opposite side, the entire turbinate lamella is pneumatized. This is laminar cell. This is laminar cell. The turbinate itself, can you see the entire length of the turbinate?
Yes, sir.
Is pneumatized right up to the skull base. You have to deal with it very carefully, otherwise can lead to fracture and CSF leak thereof. See the entire cell turbinate lamella is pneumatized. See very clear? In contrast to the opposite side, see opposite side, the upper lamella is absolutely clear, and this lower one is pneumatized concha bullosa. I hope you appreciate this,
Yes,
what
sir.
I'm trying to say. This is lamellar cell, and this is concha bullosa. Another important finding is, see, because of this CCAD presented with olfaction loss, because the obliteration of the frontal recess with some anatomical abnormality. See this anatomical abnormality, what a big cell it was. It is predisposed to the frontal sinusitis. These are the two reasons why this patient is having problems. Additional problem, the turbinates are laterally placed. Can you see this? See, this turbinate is so laterally pushed because of the disease medial to it. Hello?
Yes, sir.
Hello?
Yes, sir.
Yes. And as you go behind, that was the minimal, osteometal blockage on the right side, minimal on the left side. And now as you go behind, that's the level of the rostrum. See, this is broadening, rostrum, and it has blocked the ostia.
Rostrum is pneumatized, sir.
Yes, rostrum is. This rostrum is pneumatized here. Right side is almost completely opacified as compared to the left. So this is the picture. Now, another important thing, once you find disease medial to the middle turbinate, in such a situation, when the patient presented with olfaction loss and the lamellar cell on one side, which has to be thoroughly flushed now, because this lamella is not a very stable lamella, and it has to be cut to prevent a floppy turbinate. Opposite side is concha. Again, you have to open up and it may lead to floppy turbinate once you remove the lateral part of it. So you may have to do a partial turbinate resection in this case. That will help us opening the olfactory area as well. Generally in CCAD, you preserve the turbinate. But your concern is the olfaction, you have to open up the access to the olfaction. So we will partially trim the turbinate. In general, any patient having disease medial to the middle turbinate, you have to do a partial turbinate resection to allow the topicals to reach to the olfactory recess uninterrupted. So a lot of interesting finding in these cases, in this particular case also. Any questions? Hello.
Sir, in females, hello,
Yes.
hello, sir.
Yes, please.
Yeah, in females, sometimes we see more bleeding during surgery, like any precautions.
Not like that. It depends upon if you are on any medication. Is affecting. It depends upon the preparation also, depends upon the hormonal status, so many things. It's not, you can't say aggregate as a statement for everybody, but yes, it can.
Sir, you will address the septal spur also in this case?
Pardon?
Septal spur, you will address?
Yes. Septum and turbinate have to be addressed according to the need in every situation. The reason is you have to take intraoperative decision to ensure that your topicals are reaching adequately to the area where you want and they are not coming in the way. If they are coming in the way and becoming the site of obstruction, you have to address them.
Right, sir.
That's an intraoperative. But if they are obstructing and if you are not treating them, it's a disaster. It can lead to an ultimate failure if your topical do not reach there. So it's a very, very important part of the surgery.
So in terms of debriding the medial polypi, what counseling will you do with the patient with respect to loss of olfaction? Also with respect to chance of exposure of the olfactory fibers or CSF?
Yes. So first of all, your question is valid and I have already told certain things. In this region, you are not going to do anything to the olfactory mucosa that I will show you. Olfactory mucosa is there in the upper part of the septum, upper part of the superior turbinate, and uppermost part of the medial surface of the middle turbinate. So those areas we are not going to disturb with debrider or anything. Whatever bulky polyp or anything projecting into that area, we will debride. But the mucosa from that area has to be left untouched. If you try to do anything, you will end up giving fibrosis and that is disaster.
Right,
Even
sir.
if there are some polypoidal mucosa left, and if you have given an avenue for the topicals to reach there, it is bound to revert back to normal. You don't have to be very aggressive in the olfactory recess as far as the surgery is concerned. This is
Right, sir.
important point to preserve olfaction.
Sir, and in the morning you had said about this central compartment disease in which there is laminar flow of the airflow along the turbinate. But
Yes.
if we do a resection of the turbinate, as you just said just now,
Yes.
Will it affect the this laminar flow
Yeah.
again?
Not laminar, that doesn't affect the laminar flow, rather it opens up other areas for the allergens to deposit. It's not that it affects the laminar flow. It
Okay,
opens up other areas to be affected.
Okay.
So
Okay.
here, in this case, turbinate, as I said, turbinate and septum requires correction to prevent coming in the way of the topicals. Here, you see the both the turbinates. One is a concha, one is a lamella. And they are going to be unstable once you remove the disease from there. And they are full of disease. So in this situation, you have to do a partial resection. You are left with no choice to, any other choice. So you have to do, and we'll follow such patients with the proper anti-allergic treatment, immunization, and close follow-up. More effective, maybe more long-term irrigation and all that to deal with anything coming like that. But we cannot help it. Looking at the turbinate situation, we have to deal with it. Generally, as a principle, as much as possible, you don't remove the turbinate.
Hello, sir. Sir,
Yes.
before going for surgery, for how many days you should give a medical trial for this patient?
Such patient, yes. I mean, these are the patients who present with olfaction loss. I told you certain gray areas. And this is another gray area where the disease is so severe to have given a major symptom of olfaction loss. This is major symptom. I had given you the list of symptom, major and minor. This is one of the major symptom. Means disease affecting the olfactory cleft, eosinophilic disease, associated allergy. So it has to be aggressive. Yes, obviously, in such patients, as a medical treatment, you should try full adequate medical treatment. But that is only with a saline irrigation and nasal spray.
Okay, thank you,
Which
sir.
is, with such a big symptom olfaction loss, it is unlikely to resolve. Olfaction is a major loss.
Okay, sir.
Now, such patient ultimately requires surgery.
Okay.
See, you have to be sometime practical. When some patient is coming with a massive polyp, nobody can cure with the medical treatment alone.
Exactly.
So we are starting the case in a couple of minutes now.
Right, sir.
We can continue the question, discussion, anything. Please come out with any suggestion, questions, or anything related to FESS in this 2-day workshop, entirely dedicated to this topic. I don't want anybody, keeping any doubts in the mind.
Sir, in case of osteitis, do we find it difficult to find the maxillary sinus opening? I mean, what are the difficulties that we can face in finding the maxillary sinus ostium?
Yes. So that's a very important question. Not only osteitis, but in many other situations, you may find difficulty in sinus openings. Not only maxillary, frontal, anywhere. Or you can take it like revision situations. Osteitis is also, and revision situation is also. So, as I said, this is a surgery of landmarks. There are certain landmarks which are rarely destroyed, and use them as a preferential landmarks. Like, for example, like you asked for the maxillary sinus, inferior turbinate is a landmark which is rarely destroyed. So, like in this case, I use the inferior turbinate as a landmark, and just above the superior surface of the inferior turbinate, I went inferolaterally to open up the maxillary sinus. So, inferior turbinate is a great landmark for the maxillary sinus, number one. Sometimes in revisions, you have already maxillary middle meatal antrostomy, and you have to open up other sinuses like frontal or anything. Middle meatal antrostomy itself is a great landmark. Following that, you can see the lamina easily above the middle, maxillary antrum. Above and medially is the lamina, above is the orbit, and medially that is lamina. Following the lamina, you go to the beak. Even if you don't have turbinate, once you find the lamina and beak, follow them where the beak ends in the frontal. And follow the skull base, you can see the sphenoid. So by one landmark, you can go and find other sinus. Why I mentioned all these structures, beak is rarely destroyed in spite of multiple revisions unless the draft is done. In regular sinus surgery, beak is never destroyed, so you can always use it. Like in this case, you follow the beak where it ends in the sinus. Similarly, for behind, there are certain landmarks which are always present, like choana. Choana is never going to go anywhere. So if you see the choana behind, staying close to the septum, 1.5 to 2 centimeter above the choana is going to be the sphenoid. Once you find the sphenoid, find the skull base behind the sphenoidal skull base and follow it anteriorly, you can reach to the frontal. So by one landmark, one reliable landmark, reliable means inferior turbinate, middle meatal antrostomy, frontal beak, choana. These are the landmarks which are never destroyed. By using a single landmark, you can accomplish the entire sinus surgery. That is so important. Is clear?
Sir, sometimes in this middle meatal androstomy, we find the bone around is very thick and hard. So,
Bone around in osteitis.
So, but in how do we pick that up in a CT scan, the thickness? Because sometimes it's mostly very easy to find the middle meatal androstomy following the uncinate, but when the whole area is hardened, thickened, and
Yes.
how do
So
we?
is that a revision situation you are talking about?
No, sir, not revision, primary case.
See, primary situation I mentioned earlier. Primary situation I had mentioned earlier, osteitis rarely involves primarily the dependent sinuses. Osteitis first, foremost, and most often involve the ethmoidal septations. You may find very hard bone in the ethmoidal septations to remove, but rarely a hard bone in the maxillary sinus or anywhere region. You know which bone you encounter to open the maxillary sinus? Uncinate. That's the only bone come in the way because anterior limit is your nasolacrimal system. Posteriorly is your perpendicular plate of the palatine bone. The only bone which need to be removed, address is uncinate to open up the maxillary sinus. And uncinate is never involved in osteitis. Osteitis, I told you, first, foremost, and most often involve the ethmoidal septation. Very thick septations, you have to really use a bone punch to remove them because that is full of neosteogenesis because of the ongoing inflammatory disease. इसको भी रख लो कल के लिए ना कौन सा अच्छा ठीक है So any other questions? We are moving to the next case. ये ऑन करा अच्छा माइक इसका वॉल्यूम आ रहा है क्या इसका वॉल्यूम हेलो hello
Hello. Yes, sir.
yeah so this is an interesting situation with polyps in the olfactory area giving olfaction loss has a DNS also turbinates also need to be addressed and frontal sinus disease with a buller cell above. So lots of interesting finding in this case as compared to the previous one. So I want every case to be little different to discuss different clinical situations. And this has a DNS also. If you want me, I can show you a limited septoplasty also.
Sir, can you discuss about bulgarization? Do you do it? And if so, in which situation?
Okay. Bulgarization is another way of dealing with the floppy turbinate. See, ये क्या हुआ? If you have a floppy turbinate, you are left with certain options. Either medialize it by means of microfracturing it. दूसरा दे. Is picture good? Hello?
Hello? Yes, sir.
Is picture good?
Yes, sir. Picture is good, but CT picture is there. It's going.
Oh, not endoscopic picture.
Yeah, now we are getting the endoscopic picture.
Now see on the right side. Hello?
Yes, sir.
This is your turbinate. See the axilla above? See that axilla?
Yes, sir. Yes.
That's the turbinate and that is disease medial to it. See that?
Yeah, yeah.
On the septum, see this?
Arising from septum.
Yeah.
This is reaching near skull base.
And see this disease?
Just below
This
skull.
polyp which is attached above.
Yeah.
See like this?
Yes, sir. Yes.
And some polypoidal changes on the turbinate also. Can you see this?
Yes, sir. Very
Classical, finding. And here what you see this, what is this opening?
Maxillary sinus accessory
Accessory ostium.
accessory ostium.
Accessory ostium. One cannot see the maxillary ostium like this. This looks like posterior fontanelle. See the uncinate is anterior to it, looks like posterior fontanelle. See the findings are very clear.
Yeah.
And see this disease medial to the middle turbinate. See this is obliterating the olfactory axis. Can you see?
Yes.
This is another classical case.
Generally, no fungal element there. Allergic
No,
fungal
this
element.
is
This is
different
purely CKD.
endotype. This
This-
is different endotype. I told you 7 or 8 different endotypes with different pathophysiology. That is what precision medicine is. Don't treat every sinusitis on the same line.
Can we call these as phenotypes or only endotypes?
Endotypes.
Yes.
Phenotype is based on clinical features, what you see. That is with or without polyps. That's it. Not more than that. Now, opposite side, see the deviation. See the deviation? Septal deviation.
Yes,
Spur.
sir.
And this disease, see this disease medial to the turbinate. See this?
Yes, sir.
See the classic appearance of CCAD. See this because of the allergy, how the mucosa has become from the nasal septum. See
Yes,
this?
sir. Yes, sir.
Polypoidal mucosa. But these patients do very well. And you have to follow with the allergic treatment. These are the cases for immunotherapy afterwards or before, whatever, whenever you do. But these are the candidates for that.
Hello, sir.
Yes.
Before going for FESS, if we do septoplasty, like sometimes the flap is getting sucked in. Can you tell me any precaution to,
Yes, yes. There are
or
many.
any tip to like?
First of all, you can incise on the opposite side. Number 2, you can suture it. Wilting suture can help. There are many ways. That's a mechanical problem you can deal with. See this. See the polyps arising from the posterior superior medial part of the septum. I am sure nobody will forget the CCAD after this.
You are right, sir.
And this turbinate is a concha. See this polyp? Polyp arising from the turbinate. See this? Block the middle meatus, some polyps arising from the middle meatal structures. Can you see? I hope the picture is good.
Very
And
nice.
this is fontanelle. This is not natural ostium. This is your uncinate. Can you see?
Yes, sir.
And this is concha bullosa. You have to be very careful while removing the polyp from the medial region, as you are not supposed to go and damage the mucosa above. See what I am trying? I am not damaging the mucosa. I am just debriding the superficial polyp. I will leave this. See, whatever is coming easily, the free mucosal end, I am removing. See that? See both sides the olfactory mucosa. Can you see?
Yes, sir.
That is to be left undisturbed. See, now if I leave this thick mucosa a little bit over here, that will not bother me. This is bound to come back to normal. Once the ventilation drainage is established, once the topical irrigation, see this? Never
nice, sir.
ever be conservative to the mucosal lining in this region. See this?
Yes.
You have to be extremely conservative at this step to damage iatrogenic damage to the olfactory epithelium. Now see, whenever you find turbinates, see this turbinate laterally pushed.
Yes, sir.
When you find such turbinates laterally pushed, they become unstable. Whenever nowadays the standard teaching is in massive mucosal disease, when you have polyps medial to the turbinate, do a partial resection of the turbinate to allow, not only to treat this floppy turbinate, but to allow the solution to go medially to the olfactory recess. This is classical example. Hear this.
Sir, if there is no disease in megaly sinus, will you open it? Or
Yeah, I can see the accessory ostium, which can further, result in recirculation of the mucus. So better we will treat. Now see the concha.
full of polyps?
See this?
Yes.
Generally in CCD, AD, we don't cut the turbinate, but here we are not left with any option. Find out. I mean, it's full of disease. Right. So this is the initial preparation, okay? Before doing the proper sinus work, this was important. See the olfactory region? Hello?
Very nice, sir. Very nice.
I have left this mucosa a little bit. See this?
Yes, sir.
But since I don't want to damage the olfactory, see both sides is the olfactory mucosa.
Yes.
If I damage that epithelium, the olfaction will be over. So leave a little bit of the polypoidal thing. It will revert once the, this is re-established. See the much better picture now?
Yes, sir.
Keep improving your field. See the close-up view. What a picture. Always keep improving your surgical field by means of topical. This will always keep you oriented. The single most important region responsible for, complications is the surgical field, poor surgical field. Can you see that? Unseen it?
Yes, sir.
Only structure which is mobile in the entire lateral nasal wall is what?
Unseen it.
Unseen it. Entire lateral nasal wall. Sometimes because of the distorted anatomy, if you are not able to find it, mobility can help you. That's really very important.
This is the next lost.
See the uncinate bone?
Yeah.
Find the uncinate. In this case, how I found? Mobility.
Yes, sir.
No other structure here anteriorly is mobile. Anterior to this, see the interior of the maxillary sinus? Now, if you want to enlarge at point of time, see what you can do simply. This is through biting. Can you see?
Yes, sir.
Through biting, you can enlarge with the help of through biting, like this. This is just to tell how one can enlarge. See, I have a good opening now. See the maxillary sinus. I need not to do anything inside. This is bound to revert back whatever mucosal is. Agreed?
Yes, sir.
See now, the picture is good. Now moving to the next step. Very important step. This one, upper part. Go behind. This is a very important step. Go behind and fracture it. See, go.
Yes, sir. Fracturing of uncinate.
See this way. Why this anterior movement is safe? This is the closest structure to the lamina papyracea. The moment I remove, lamina will be in front of us. See this?
Yes, sir.
Closest structure to the lamina. See the lamina behind? Can you see?
Yeah, very nice.
If I don't go behind and push anteriorly, one can easily damage the lamina over here. See this?
Yes,
See my lamina? So go behind this and fracture the uncinate anteriorly to protect it from unwanted damage. I hope it is clear so far.
very clear, sir.
Now I'm opening the axilla. See this, opening the axilla. This is your lamina, very clear. See the lamina. Of the middle turbinate, medially. Now the $1,000,000 question is how to access the frontal sinus in the simplest way. You have lamina in view. You have turbinate in view. Now reaching the frontal is much easier with the technique I am just again showing you. Only two things needed. Third, we will discover as we have opened the beak area to see the, open the axilla to see the beak. Now let me show you 70 degrees. So far clear? Anybody please feel free to interrupt me on the slightest doubt anybody has in mind. Changing to 70 degree now. Now, see with the 70 degree now, get used to 70 degree. The best work in this region, frontal. People losing confidence in the frontal sinus are those who are not well versed with 70 degree. So get used to, by any means, by cadaveric work or anything, get used to instrumentation while using 70. Get used to identified in structures while using 70. See. See now with 70, everything clear? See, I am looking up with a 70 degree. One by one, I'll show you the structures. This is the medial area. And your stump of the middle turbinate is guide. You are not supposed to transgress that medially. Okay? Hello? I have my lateral limit as a lamina in view. I have
sir.
my see this. See the level of the, I am working close onto the beak. Just identify the beak, nothing else. See the beak?
Yes, sir.
Just follow the beak where the beak ends in the frontal. Simple. See the beak, the toughest bone in this region. Stay between your medial and lateral limit. Between these two limits, follow the beak and you are in the frontal. Nothing, nowhere you can go. See now. Can you see the
Sir, what shaper are you using? This is a RAD
120.
60?
Can you see the beak?
120.
Can you
Right,
see
sir,
the
right.
interior of the frontal sinus?
Yes, sir. We
Yes,
can.
sir.
See now. There is nothing great I'm doing. See this simplest. what I'm trying to show again. This is your beak. Can you see?
Yes, sir.
One can easily identify the axilla. See this? This is the thickest bone in this region. Stay between your lateral limit, medial limit. This is your lateral limit lamina. Stay in between these two. Follow the beak, follow the beak, follow the beak, where it ends in the frontal. Can you see very clear? There is nothing great, nothing to hide here. Can you see very clear or not?
Yes, sir.
Anybody in the audience, any doubts, please come forward. See this again. This is your lateral limit. This is your medial limit. This is beak. And to follow the beak, see my instrument. Where it ends, you enter into frontal. There cannot be any more simplified version to enter into the frontal than this, in my opinion.
Hello, sir.
Yes, please.
Hello. Sir, without this 120-degree shaver, how can we approach?
How can you approach? Like any other blade means. Same way, I'm using 70 degree. See now my frontal is behind. I can clear all these cells anteriorly because now my skull base is far behind. Try to understand. See, you have to define your safety limits. See this. Can you see the frontal above?
Yes, sir.
Yes, sir.
See how the beak is, giving you avenue to enter the frontal. That is the beak. Can you see the mucosa over it? That
Yes,
is
sir.
all beak, and you enter into frontal in no time. See this direct entry into the frontal. This is the simplest way of, reverse of entering into the frontal. Now, see
Can you show us the RAD 120 blade, sir? Once.
Yes. This is 120-degree blade. Can you see?
Yes, sir. So you use this regularly for frontal sinus, sir?
Yes. And now
You
I'm
don't use RAD 60.
using the reverse blade.
Okay.
I call it a skull base blade because now I'm clearing along the skull base. See this. See the frontal sinus. In no time, we could clear the frontal. There is nothing, I mean to say hidden, nothing challenge if you follow the right principle. Beak, beak, beak. See this.
Sir, you were telling about the frontal bulla cell.
That is on the opposite side.
Okay, not this side.
Not this side. So this side, we have done the frontal sinus work like anything. See this? Wide frontal sinus 120. With utmost safety because we are far anteriorly. Our cribriform plate starts more than a centimeter behind the beak. More than a centimeter behind. Let me tell you what do I mean. See, this is the level of the beak here anteriorly. Cribriform plate is more than a centimeter behind. More than a centimeter from the beak. So don't terrorize yourself. See the frontal. Very clear. And there's good mucosa inside. You don't have to do much into that. Plus 60. See the frontal? And now the ethmoidal roof, and I can flush them. Again, my same landmark. This is my lamina. This is lamina, which is lateral. Can you see the lamina?
Yes, sir.
This is your turbinate. It's a great guide. Now see, I will show you something. Can you see some vessel behind? And see, you were asking that time about the anterethmoidal artery, and I was telling you how far behind it is. See this. Can you see some vessel behind obliquely? Let me clear that area so that I can give you, how confidently one can, remove the cells in this region. This is my lamina laterally, lateral limit.
Yes, sir.
That is the anterethmoidal artery. See there?
Yes.
And what is anteriorly is the anterior attachment of the bulla onto the skull base. This is the anterior attachment of the bulla anterior to the artery. See, the artery is there behind. Can you see?
Yes, sir.
Just anterior to my section. Can you see or not?
Yes, sir.
Hello?
Yes,
And
sir.
this is the anterior attachment of the bulla anterior to it, which I can fracture now. See this? No fear. No fear at all. I can fracture and flush this frontal sinus with the ethmoidal roof. See this? Now see, this was the frontal sinus. Just a minute. See the frontal sinus above? This is a shallow supraorbital recess. See this? Shallow, not like previous case. The shallow supraorbital recess, and behind that, that is the anterethmoidal artery. I hope it is very clear.
Yes, sir.
The most important thing, see everywhere, the mucosa has to be left intact. See this? Nowhere the mucosal stripping is done. Can you see? This
Yes,
mucosa
sir.
is most important to serve the function. Reverse. If the mucosa is lost, the raw bone will invite fibrosis, and that's a big problem. Then then it cannot be functional. It is not functional endoscopic sinus surgery. See now, right from the frontal sinus till anterethmoidal skull base. Can you see very clear? See the region. I hope it is very clear. See the entire frontal sinus till anterethmoidal roof is clear, and my turbinate stump is there medial to it, and the olfactory recess is medial to it. See everything in order under vision, and this is your lamina papracia. Now in this sinus, what is left behind to us is the postethmoid and sphenoid. His opposite frontal has a cell. See this? I hope it is very clear. Now changing to
Sir.
0. Yes,
Yes.
changing to 0 degree again. Give me a small दो मेरा सेल छोटे छोटे बिल्कुल छोटे. See, one small piece of mirror cell above in the olfactory region. Now I'll leave it. I don't need to go there again and again. And one in this region. Wash kar de bas. See, back with the 0 degree. Out section. Mucosal preservation is of utmost importance. See this, all mucosa, everything intact. Now coming to the level of posterior group of cells. Now at this level, my first thing, your post-ethmoids, I can see. See, this is lamina. See, this is the part of the bulla which I have removed. See this? Now, this is the level of the roof of the maxilla. We call it as a maxillary line.
Sir, what is the speed of debrider used generally, sir?
5000 RPM. Now, entering into this post-ethmoid. See here, entering into it. This is my superior turbinate. Can you see?
Yes, sir.
Suction periosteum. See, let me tell you, entry into the sphenoid. The best way to enter into the sphenoid, safest way to enter into the sphenoid. See, this is my suction elevator. Don't go above this level of the maxillary roof. See this? Either it's this level or below, and go along the septum. Glide along the septum. See this? Along the septum. Glide along the septum medial to the superior turbinate. Medial to the superior turbinate. And see here. Medial to the superior turbinate, but glide along the, that is your sphenoid sinus ostium. So always medially, so your all critical structures are left laterally. See this? Always stay medially. Widen. See this limited mucosal disease here. Widen. Could you see?
Yes, sir.
That is the sphenoid sinus. Once you have seen the sphenoid, you have seen the ethmoid, this post-ethmoidal group of cells. Now I can come from front to back, back to front, knowing the level of my sphenoid ostium, not to cross it behind. See this? I will not go behind this way. While doing post-ethmoidectomy, if you don't cross the level of the sphenoid ostium, you can never damage anything behind, even if there is an ONOD situation. See, all these cells I am excentrating. Last minute, and this side is finished. That is the post-ethmoidal roof now. See this? See the post-ethmoidal roof?
Yes, sir.
That is the post-ethmoidal roof now. And now I am finishing off. See, this one of the post-model cells from here, if it happens to go beyond the sphenoid is called onody. If I keep going behind here, I can hit the optic now if there is onody. So best is this is sphenoid sinus. See the level of the sphenoid sinus and don't go posteriorly behind the level of the sphenoid sinus. You can never damage anything. To me, this side FESS is done for this patient. You can see all the sinuses.
Sir, how wide you open the sphenoid sinus generally,
Yeah.
sir, in every case?
Generally till lateral wall. Till the lateral wall here. See this here?
Okay.
See the lateral wall. See, with clinical experience, you get to know what is minimal, so which doesn't stenose again. If you leave a small opening, it may stenose. See now, right from the frontal above to the maxillary, sphenoid, ethmoidal roof, a partial turbinectomy, and most importantly, our olfactory area is opened up. See that? Can you see the olfactory area? So when
Yes,
this patient, you can follow such patient with your 0 degree in your OPD, outpatient department, and see this. My solution will freely go to the olfactory area. This will revert all this epithelium inflammation back to normal. See this?
yes,
You
sir.
are not supposed to damage that region at all. Don't do any stripping in that region to give a permanent olfactory loss. See this?
Yes, sir.
This side to me is done. See now, full house FESS, good access for the topical there. Good access for the topical. All sinuses have been addressed and can be monitored in future with your endoscopy without the need of any radiology. Any questions for this side? Now, coming to the opposite side and see the problem there. The biggest problem is the nasal septum. Now, if suppose I find that I have good access and I can go ahead doing this. My instrumentation damaging the opposing surfaces. Can you see? My instrumentation damaging the
Yes, sir.
opposite surfaces can leave raw areas and can invite, adhesions. Can you see? So here
Yes,
I
sir.
will do a septoplasty. Okay?
Okay.
I have not infiltrated, only the topicals I have used. And here I will do a septoplasty here. See, no infiltration at all. See this deflection of the cartilage. Hello?
Yes, sir.
See the deflection of the cartilage. See, going to the opposite side. Can you see?
Yes, sir. Yes.
And this is the major deflection. That is the perpendicular plate of the sigmoid bone. Hello. Hello.
Hello, sir. Yes, sir. Yes, sir. We are here.
Now, let me show you something. Can you see the space opened up behind?
Yes, sir.
See the middle turbinate here. See,
Yes,
the
sir.
middle turbinate was so pushed laterally, paradoxical here. See this is middle turbinate.
Yes,
This
sir.
was the polyp there, and this is the disease at the septum. And the septum is straightened behind. Can you see?
Yes, sir.
Very clear or not?
Very, very clear. Sir.
Now I'm taking care of this like the opposite side we did. Same thing. See now the axis. See this turbinate is so floppy.
Yes, sir.
And this, see this polypoidal?
Yes, sir.
Little bit. Not going to the mucosal level. See, I have opened the access to the olfactory. See this? I'm not
Yes.
going to remove this mucosa now. That will damage my olfactory mucosa. Got my point? I've opened the access. See this? My topical secretion will go there and take care of everything. Now this turbinate, you all know, is a lamellar cell. This is because of the disease there on either side, it has become unstable. Can you see?
Yes, sir. Yes.
With such a massive disease, medial to the turbinate makes the turbinate unstable, has to be dealt with definitely by means of partial resection. There is no other way. Now see, this is your uncinate evertate. Now see the anatomy opening up. Can you see very clear now?
Yes, sir.
See the access after the limited septal correction. Can you see?
Yes, sir. Yes.
Earlier there was not even, full visibility of the areas behind. But that kind of visibility, if you try to do, will end up giving complications. As simple as that. Now this turbinate has to go. There is no other way, no question about it. Under करा दे. See, this is the lamella inside the turbinate. Can you see?
Yes, sir.
This is lamellar cell. That can never be stable.
Sir, you are still using RAD 120 or RAD 40?
No, straight one.
Straight blade,
Yeah,
eh?
that 40.
RAD 40, I think.
See now? This
Yes, sir.
is dealing with the turbinate. Now we are opening our axis. See everywhere? See, so far no sinus work has been done on this side. Just opening the axis, nothing else. What is it now? See? See that? Somebody was asking if your flap comes in the way. See this? Hello?
Yes, sir.
Introduce your scope over there and now introduce your instrument. See this? I've shifted myself little medially, little inside. See, my scope is there across that. That is keeping my septum in place, my flap in place, and my instrumentation are lateral to it. Simple?
What about suction, sir? When you put suction because of negative pressure?
Nothing. My this telescope is taking care of everything.
Okay.
See, telescope, I push little medial, little inside. That's it. So simple. So don't bother about that. Now our sinus work will start. I can suture it also any point of time. Okay?
Okay, sir.
Suture kar dena. Yeah.
Sir, for irrigation, use saline or?
Ringer. Best is ringer now. Now see. Now the picture is good for the sinus work.
Yes, sir.
See now everything distorted again. See this. Because of the disease, polyps, things have been distorted. This is, that is my uncinate. See this? See this?
Yes, sir.
That is mobile uncinate. This is fracturing the horizontal uncinate. See this? To create the middle metal antrostomy.
Sir, anytime do you use antrum punch forceps to widen? No need.
Not really. Now see, this is your middle metal antrostomy. You actually don't need to enlarge it because there is, nothing in major disease inside the sinus which is directing you to do that. Now this is your upper part of the uncinate. Be careful. Your lamina is adjacent. See the lamina behind. The uncinate bone is very, very thin there. See this lamina there.
Yes, sir. Yes, sir.
Uncinate bone has been so thin, so that's why always while removing, see this? See the lamina behind? See this?
Yes, yes, sir.
See this lamina?
Yes,
While
yes.
removing the upper part of the uncinate, that is the closest structure to the lamina here in this region. Now I am opening the axilla. See laterally my landmark is lamina. Same thing, repeated rehearsal, same thing. Now, see this? We have middle meatal antrostomy below. We have lateral limit as lamina behind. Can you see this?
Yes, sir.
We have axilla, and now is the time to use 70 degree. Give me a pack. We have a bular cell here, which is posteriorly attached. See now? See the beak? Very clear?
Yes, sir.
Now, first of all, entry into the frontal, and there is a narrow space. We know because the cell from posteriorly is narrowing. Remember the CT scan?
Yes.
Hello?
Yes, sir.
Yes. Yes. Now see. See this beak?
Yes, sir.
I am following the beak. Following the beak. See, follow the beak. Nothing great. Same story again. And I am in the frontal. Let me show you. Wait. Look down. See, I am in the frontal. Can you see the frontal above? Just follow the beak, nothing else. See that? That is frontal sinus. And what is this ballooning from behind is that cell. See what is there behind in the frontal sinus. Can you see?
Yes, sir.
That is frontal sinus there. And this cell, see this cell. This cell is narrowing from behind. I will take away this cell now. I've opened from front and see the cell is collapsed. One down there. See, widen the opening. I know the cell is attached after. I didn't go behind a cell and see my frontal sinus opening widen. That is my frontal sinus opening which is widened. Can you see?
Yes, sir.
See, that is the frontal sinus. Now I will widen further. That is my frontal sinus. That is your frontal sinus, up and behind. See that?
Yes, sir.
Very clear? Now let me clear it up. What I did simple, I knew the cell was behind. I opened up the cell from front. That's it. Bottom line is you should know where the cell is, how it is oriented. Then you can do accordingly. See that? See the frontal. Give me a pack, small pack. Clean the field and show them. See the cell behind, which is ruptured. See the frontal sinus behind. So getting into the frontal was same. With the same ease, I got into it. In spite of being cell, since we knew the cell where it is, I ruptured the cell from front and we went into it. As simple as that. So don't terrify yourself. Whatever the anatomy is, what all is required is to know from radiology that what kind of anatomy is there. Accordingly, you can treat it. Once you know, you can treat it. Problem comes when you don't understand the radiology and go there blindly. And that can be picked up. See, this cell could not have been picked by anybody in the world on printouts. This requires dynamic imaging. I showed you with all the 3 dimensions together, and that is how it can be simply picked up. Don't rely on radiologists to give you that kind of information. They themselves don't know what all you want, what is this cell, what is that cell. They have never been trained like that to read all these cells. So the onus is on us, ourselves. See this? Can you see very clear?
Sir, do you ask for this thing, sir, navigation protocol or what?
Just 0.5, 0.6 to 5 mm scan, and then rest is done by your software.
Okay.
More you ask radiologists, more they will charge unnecessarily. As simple as that. You just ask them, give us fine sections in a CD, in a DVD, that's it. Don't tell them what you are going to do with that. You know, once I told Dr. Sethi, we had a lot of discussion on this. So he went back to Singapore and asked for the 0.5 mm section for the sinuses. You know, their CT scan is so costly. They calculate by number of slices. When I got the CT scan done in Indian rupees, that CT scan to the patient cost almost more than 1.5 lakh rupees. They calculate in terms of slices, number of slices.
They will learn.
And you know, there is a reason to it. All CT machines, you know, they take insurance. All radiologists take insurance.
Yes.
And that insurance is based on number of slices.
No need to do surgery.
Accordingly, they charge according to the number of slices. More finer the section you ask, more they will charge. See now the frontal sinus crystal clear. This
Yes, sir.
patient had a frontobular cell. We opened the frontal sinus with the same ease. Went underneath the beak. See the beak now? You should be able to identify this beak. See this beak?
Yes, sir.
See the axilla. Anybody can identify the axilla. See this axilla? Go underneath the axilla, see the beak, follow the beak where it ends in the frontal. See how the beak is ending into frontal. Can you see?
Yes,
This
sir.
is God's given natural anatomy. I am not doing anything to it. We are just utilizing this information, exploiting this anatomy, which is almost always fixed. You know,
Yes.
a lot of people explain the frontal sinus in terms of this block concept, this block concept. You have to identify this number of cells, that number of cells. All those cells are never constant. Utilize the landmark, first of all, which itself is reliable. And there cannot be any other landmark in this region which is more reliable than the beak. Okay? So always consider beak as one of the best landmarks, I tell you. Anybody has any doubts about the frontal sinus? That is maxillary. See this maxillary with the 70. That is your lamina. Above the maxilla is the orbit. The medial wall is lamina. And along the lamina, between lamina, beak, and the turbinate, go anteriorly. There is the frontal sinus. And this is almost always a fixed anatomy.
Excuse me, sir. Excuse me, sir.
Yes, please.
Sir, can we see the picture outside this endoscopic picture? The position of the patient and your instruments.
What I will do in the next case, we'll put up the external camera together.
Yeah.
Okay?
Thank you. Thank you.
We want to see ergonomic position.
Yes, yes. So anybody, any doubts in the frontal now?
Excuse me, sir, I had a question that you're using this 120 angled wand of the debrider, but if we don't have access to that, what can we use to achieve the same result that you have got?
See, people have done a lot of things. Cut one point. This is direct method because the frontal sinus is so strategically located anterosuperiorly, you know. And to reach out under vision, 70 is the answer. Ideal. Now, if you're saying there is no 70, then you have to deal with this beak. The obstacle, why we use 70? This is the obstacle. The beak is the obstacle. Tomorrow I'll show one or two draft cases where the beak is the obstacle and we drilled away the beak. Now, in situations like this where you need not to drill the beak with no 70 degree, what you need to do, people are doing a lot of things. People are making the flap here. People are, taking away the part of the beak here. People are making window like Caroline window or something. There's so many, ways people have made, but all those are, nothing can be as direct as 70 degree. That now.
So we have 70 scope, but I'm talking about this debrider wand angle. If we don't, we have 70, but we don't have.
You can have 120 debrider. If you have debrider, why don't you have the 120 blade also?
They have not provided.
Yes, you can have. This is really useful for frontal
Okay,
and.
but if it's not there, then what other instrument can we use?
All angle instrument, but they make your life so difficult. See now the skull base behind.
Sir, can you show us the anti-leaf model in this?
Yes,
side?
yes. See this? Keep skeletonizing the lamina for your orientation. This is the best landmark. See the lamina. Always, always the best landmark for this region. Anterethmoidal runs along the skull base. Don't terrify yourself once you are doing. See, this is anteriorly, this is deep in the skull base, deep, 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 deep there. Right into the bone of the skull base, the anterethmoidal traverses. Okay? So don't terrify.
Okay, sir.
Flush the skull base.
Sir, have you counted how many cells are there each side?
Why to count? Can you see the vessel there?
Yes, sir.
See, this is the skull base. The vessel run along the skull base. Can you see very clear? Hello?
Yes, sir. Yes.
See, everything has to be mucosal. Now, about counting the cells, the important thing is not to leave any cell unopened. See my limits flushed. Can you see?
Yes, sir.
Along the lamina, all cells flushed. Along the turbinate, see this? Ostium.
Yes, sir.
Yes,
Yes,
sir.
sir.
Now, staying anterior to the sphenoid ostium, finish your post-ethmoidectomy. See this? Simplest way. Keep the sphenoid ostium in view in 1 minute's time. This is now fast endoscopic sinus surgery. Different FESS. See now?
Yes, sir.
Retrograde, flushing the. See this? Another way of doing the same thing. See now? Everything done?
Yes, sir.
See, all these post-ethmoidal cells I am removing in the end after having opened the sphenoid sinus. So in any given situation, I don't go behind that. See this? My sphenoid is so deep. See this?
Yes, sir.
But my limit, trying myself to keep anterior to this ostium. I don't go there. That's the point I wanted to make. Because if it is onodi, there it is going to be the optic nerve. See this? All flushed anteriorly, all post-ethmoidal cell, that is all lamina.
Sir,
No cell there.
laterally and inferiorly, the sphenoid sinus, can it be widened still more?
That's
Or
what
is
I
it-
am doing now. See this?
Yeah. Carry some sponge. Yes.
You can use sphenoid punch, you can use drill, you can use debrider, you can use any instrument.
Yes. Do you advise wide sphenoidotomy?
Yes. See, the aim is to introduce your topicals later on. See this?
Yes, sir.
I don't recommend widening inferiorly, otherwise you can damage the vessel. If you want to further widen, through it. I can widen with a punch anteriorly. See this? I
Yes.
can widen it anteriorly here safely. Rather than widening inferiorly to damage the septal branch. Okay?
Okay. Okay, sir.
That was the party wall between this and the onodi cell.
Yes.
So this is all about the sinus surgery in this particular patient. This is a classical example of CCAD. See this? The medial part, only thing the turbinates were diseased having concha, laminar cell, they themselves was harboring the disease and unstable, so they had to be removed. There is no way out, you know. And this is what about the limited septoplasty we did. See the excess on this side. Earlier, there was no excess at all, if you remember.
Yes, sir.
Okay. Thank you. Now the last case of the day is coming. It's a bilateral FESS. Probably I'll show one side so that we can, finish before 7. The other side we are not going to demonstrate. And that's again a patient. Any questions?
So would you consider this to be a type 2A frontal sinus draft opening of the frontal sinus?
Pardon?
The opening that we have seen over here that you have made in the frontal sinus.
Yeah.
That is basically a draft 2A.
Yes, a lot of people call it draft 2A. Lot of people call it draft 1. Draft 1 is excentrating all cells to the level of the ostium.
Okay, sir.
In regular sinus surgery, you are not supposed to go to the level of the ostium. Just widen the cells below that, below the frontal sinus ostium, not to the level of the ostium.
Means
when
in
you
the frontal
widen to the
recess.
level of the ostium, it is draft 1. Some people call it draft 2A, and once you remove the anterior wall, they call it draft 2B. Some people call draft 2A removal of the anterior wall till the middle turbinate medially, and draft 2B till the septum. So like different terminologies. Why to fall into controversial terminology? So
Okay,
you
sir.
can call it whatever.
Right, sir. Right, sir. Thank you, sir.
Any questions before moving to the next one? Hello.
Hello, sir.
Hello.
Hello, sir.
Yes.
Sometimes patients, they come on their own. If we write some medicines, they will not come back. So what to do in that case?
I didn't get your question. Please, can you repeat?
Sometimes the patient comes, we need you told me surgery 3 months back, like that. In that stage, maybe she was having some mucopus in the sinus, middle meatus. Can we operate?
Yeah. So what was done earlier? It all depends upon.
No, surgery was indicated previously, and she came back after 3 months when the symptoms were more. Can we do directly surgery, or do you advise to give her antibiotic and do surgery?
See, you have to assess whether medical treatment is not curative. See, every patient is different. So if you find the entire profile indicating medical treatment is not going to work, better, operate. But you have to prepare for that.
Sir, one more question. Sir, in the second case, whenever you are packing the nose, do you give pack in the middle meatus, sir?
Yes.
In both
For
sides?
2 days.
For 2 days. Okay.
Yes.
And along inferior turbinate, the other one, I mean, 2 packs on each side, like that, sir?
2 packs. 2 long packs on each side.
Okay.
And rest small in the cavity.
Okay. And all the packs are removed after 2 days, I mean 48 hours, right, sir?
Roughly.
Roughly, right, sir.
Which pack you prefer, sir, to avoid adhesions, sir?
Using simply Merocel, nothing else. See, adhesions will form
sir,
if you don't correct the turbinate and septum. When your
so-
opposing surfaces are close by, then only adhesions can happen.
Sir, do you use any antibiotic or steroid solution to moist the Merocel, or just
Yes, steroid soak Merocel.
And sir, what is the steroid concentration you use to soak the Merocel, sir? Just
Dexona, simple,
simple Dexona. Neat.
most economical. Yes.
Okay.
So do
Thank you,
use
sir.
paraffin around the merosil to prevent pain
Yeah.
while removal or something?
You can use that just before removal,
Not during packing.
not during. Because you are operating under general anesthesia, while you remove, you can start, soaking in paraffin half an hour before.
Okay. Thank you.
So what of the intraoperative BP and pulse in the last case?
Same normotensive, pulse around 60. I saw 57. Kitna tha? Yeah, 57, 60. Lower pulse is most important to reduce the cardiac output.
I think dextromid was used, no?
Pardon?
I think dextromid was used.
Dexmed.
Yeah.
I don't know. Our anesthetists try different combination, but they use sevoflurane, they use probably midazolam and some beta blocker. A lot of people use clonidine, a lot of people use beta blocker. There are many ways to. Dexmedetomine is one of the way. Many things. That is anesthetist domain. What we want is a pulse around 60, whatever way they bring.
Sir, there are some dissolvable packs which need not be removed. Do you
Yes,
have any experience with that?
Merogel. Merogel
Merogel.
packs are available, but
Is it?
Merogel induces a lot of fibrosis.
Okay.
So it has been, disregarded now. And a lot of people who were using earlier have given up.
Okay. Thank you.
Now, regarding the last case, we have to finish it anyhow before 7, the demonstration part. So I'll show you on one side quickly. We have seen most of the things, in both the cases. 3 sides we have seen so far. So one side I am going to demonstrate here, and I'm going to show you certain positive findings in this case. This particular patient, he has a pansinusitis. This is pure eosinophilia. And see this. Frontal, hardly any challenge. Good frontal sinuses. This is beak. This is frontal drainage. See the turbinates. Can you see? Hello? Turbinates, lateralize, and a lot of disease medial to the turbinate. Again, can you see this?
Yes, sir.
That is something. Once you have a disease medial to the turbinate, you have to, resect it partially to give access to the topicals to reach inside the olfactory region and other areas. So this is one. Number 2, see, almost white out. I can see optic nerve all in place. Nothing is lot of polyposis. So nothing much to comment, a regular one. We have already discussed the things this patient has already in the previous cases. So this is a rehearsal of what we have been doing in the previous cases. What I can see, the turbinates, a lot of disease medial to the turbinate. Massive. See, you have to see quickly the challenges one can come across. That is important. Any bone erosions outside, any breach in the walls. See the anterior artery, which is should be prominent. There is a cell above the level of the ethmoidal artery between the space between the artery and the skull base. Can you see? So you have to be careful at this point, because your artery is running below the level of the skull base. One can damage if not careful. Level of the, orbit and the medial wall of the maxilla. Good. Hard. Some septal deviation on this side you can see. See this? will require a limited septoplasty like previous case. These are all ethmoidal cells, anti-ethmoidal cells. Little bit of the supraorbital recess like this, not much, not like the first case who had big supraorbital recess, but it is a shallow supraorbital recess, and the frontal, the big frontals, and this. So let's quickly, any questions? Hello?
Sir, right frontal drainage, can you describe, sir, please?
Right frontal drainage is hardly any challenge. See, that is the challenge is that ethmoidal artery, important finding, supraorbital recess anterior to it, frontal sinus. See this, anterior to posterior, how to go. See, this is anterior most. Now I am going posterior. First thing is the frontal. See now, first thing is the frontal sinus, anterior to posterior, frontal sinus, sinus, and the floor is made by beak. Sinus, floor is made by beak. Now the beak has gone. This is how we open the frontal. Go along the beak where the beak ends behind the frontal. Can you see now?
Yes, sir.
That is the point. That is the point. Now frontal has gone. The anterethmoidal roof has come. See, I am going behind. Anterethmoidal roof, cribiform is there. Coming behind. Now behind is the anterethmoidal artery. See how far behind it is.
Yes, sir.
Got my point?
Yes, sir.
Frontal sinus, the beak has gone. This is more than a centimeter behind the beak. Don't terrify. And now once the artery is gone, now see the postethmoidal roof starts. Flat,
Yes,
more
sir.
flat. See the more thicker, more flat, and the postethmoidal artery running through it, through the thick bone is rarely visible, rarely prominent. Because this roof is much thicker than the anterethmoidal artery where it runs to the anterethmoidal roof. Okay. Now this is again the postethmoid now, where the sphenoid starts. See this posterior ethmoidal roof is formed by all the way by this frontal bone. Can you see? Terion to terion, this entire frontal bone is forming the roof of the ethmoids. Now, if I go behind, now I am going behind. Now see that frontal bone is gone, and this is the lesser wing of the sphenoid comes. When lesser wing of the sphenoid comes, below is the sphenoid sinus.
Yes, sir.
Now it is sphenoid sinus. Okay. That is the optic now. That is the depression of the optic now. So this is, this is sphenoid process. This is optic now. Orbital apex. This is superior orbital fissure. And if I am coming anteriorly, see this is sphenoid. Now this is postethmoid. Now this is postethmoid again.
Is there a nodicell left on left side?
Onodi, yes, looks like. See how to see in dynamic imaging onodi. Let me reconstruct to all three planes. Onodi means one of the postethmoidal cell is going behind and above the sphenoid. This sphenoid sinus, and see this is proper sphenoid sinus, smaller one on this side, the bigger one on the opposite side. And this section is right at the level of the intersphenoid septum. It looks like a small cell. This is the bigger one. This is opposite sphenoid. This is left side sphenoid, smaller one. See this smaller sphenoid. So I don't see any onodi kind of a situation here. It is crystal clear. The sphenoid is rather smaller. And you see, this is the level of the posterior septum. See, posterior septum, here the rostrum forms. And here close to the rostrum, see this, close to the rostrum, you have to enter into the sphenoid. Just along the septum. That is the best way. You cannot disorient if you go along the septum. So can we start now?
Yes, sir. Sure, sir.
This patient has massive eosinophilic disease, massive polyposis, and now You must have tired by now this morning. So this is going to be the last case for before the evening party.
We are not tired, sir, when our teacher is not tired.
I know, must be tired.
While entering the sphenoid debride. Septum की debrider का अपना blade should be towards instead of enter करते हैं away
Toward the septum.
towards the septum.
Medially safe, है ना?
चाहिए.
हाँ. Can you change to the endoscopic picture? बोलो. Hello?
Yes, sir.
Are you getting the endoscopic picture?
Yes, sir. Yes. Sir, any oral steroids given to this patient?
Yes, for a couple of days. See the polyps. See polyps. Everywhere polyps. See this?
Only for
Massive
couple of days,
polypoid.
sir.
Pardon?
Only for couple of days, sir. Steroids?
Yes.
3-4
See
days.
this? Yeah, probably 5 days or so. See, the first part is luminal clearance of the polyp. See this? Imagine the massive polyposis this patient has. Now, we were discussing in the morning about the surgical indication. With such patient, day one, you have to keep in mind this is not going to be cured by any medical treatment. This will require surgery. You can give medical treatment for the regions, but this is not going to give you cure. So in such cases, you can think of, preparing patient for the surgery from beginning. See the nasopharynx?
Yes, sir.
See, lot of polypoidal disease medial to the turbinate. See this? See olfactory cleft? See this?
Yes,
Don't
sir.
be aggressive. Just whatever elevated mucosa, edematous mucosa you can debride, leaving the rest of the mucosa there. You don't want to damage the olfactory. See the turbinate, condition of the turbinate. See? Pushed
Yes.
laterally by the disease. Disease was on either side.
Sir, when do you use navigation in FESS?
Rarely, once you have a massive revision case, multiple times revision, anatomy completely distorted, massive bone erosions, making identification of the structures likely to be difficult. Those situations. See now, after polyp removal, the picture is much clear. The turbinate is there. See this? See this uncinate process, bullite modalis. Can you see all?
Yes, sir.
Yeah. And now this is partial turbinectomy. See the turbinate branch. This is done to give access of the topicals medial to it. the morning discussion, the emphasis was on understanding this disease. You can diagnose properly the proper endotype, direct your treatment properly. Surgery is a mechanical job, and this surgical understanding, of course, important, is based on radiology and execution according to the practice and skills. The practice. See now, this is the point. Now I will give a, pack the area for a while for a decongestion. The reason is what I have done until now is nothing into the sinuses, but just rest of the work to start the sinus work now. Now see. Keep improvising the surgical field in between by means of keeping the marrow cell. This improves your visualization. See this? See, such areas, never ever try to coagulate or coagulate or do anything that can ruin the olfactory, epithelial. Just leave it aside, leave some pack, forget about it, and work in other areas. See, your irrigation improves your field dramatically.
Yes, sir.
Now, your landmarks. This is your hiatus semilunaris inferioris. See this? This
Yes,
is your
sir.
uncinate, mobile structure. This is your prominence of the nasolacrimal duct. This is your bulla ethmodalis. So here is your infundibulum. This hiatus semilunaris is leading laterally into the infundibulum, wherein the sinus ostium opens. Use a reverse biting, insinuate in this hiatus. See the level of the inferior turbinate just above it, and then direct little inferiorly and come anteriorly, biting through. Come anteriorly until you come across the hard bone. Once you come across the hard bone, that is the time to stop to prevent biting through the nasolacrimal duct. So, direct your instrument inferiorly to stay away from the nasolacrimal duct. Now I am in the maxillary sinus. See this? This step we have seen couple of times. So I am going, we can go fast.
Sir, this 120 angle blade, will it reach the anterior part of the maxillary sinus?
Pardon?
This 120, that 120 blade you are
For the
using.
anterior part of the maxillary sinus?
Yes, yes. Will it reach,
Yes,
sir?
120, yes. See now the maxillary sinus not having massive disease. See, this is mucosal edema which is going to settle down. As the ventilation drainage is established, this is not looking like an irreversibly diseased mucosa. Okay. Now this is most important. What is that? Upper part of the uncinate. See this. Go behind. Go behind and fracture it anteriorly. Go behind and fracture it anteriorly so that you automatically get away from the lamina. See this? See the lamina behind?
Yes, sir.
See the lamina papyracea? How close it is, this is lamina papyracea. If you don't fracture it entirely and go with your instrument, you can go into it.
Yes.
See how close the lamina to this structure. Now reaching to the level of the axilla. Same what we did in the previous case. See the upper stump of the middle turbinate? That is lamina papyracea. Now, this is the opening the axilla. Now changing to 70 degree. Give me a peg. Same story. This is like rehearsal, you can say. Yes. Show this. $70. See now? Can you see the beak now? First of all.
Yes, sir.
Are you able to see the three structures together?
Yes, sir.
The beak, see this. The beak, the lamina and the turbinate all together. Can you? Hello?
Yes, sir.
Now see where I am going.
Along the
this?
beak.
Along the beak. See all the three structures I am able to see the turbinate, the lamina,
Lamina.
turbinate. If I cross the lamina, I will be in the orbit. If I cross the turbinate, I may hit the skull base and CSF leak. And how am I able to see all the three together? By means of 70 degree.
70 degree.
See now I am going along the beak. See this. Just flush to the beak. Don't apply your brain. Just go flush to the beak, flush to the beak. Where the beak ends. This is your frontal sinus.
Yes. Very nice.
See the frontal sinus. I am inside the frontal sinus. Yeah. See this. That is your frontal sinus.
Yes.
Can you? There cannot be any simple technique than this to get into the frontal. Tell me honestly, is that really difficult?
In your hands, not, sir.
What my hands? What? The anatomy is same. See, so simple. All the three things you operate, the anatomy is going to remain same. This is God's given anatomy.
Sir,
this.
if there is extensive anterior pneumatization of the frontonasal process of the maxilla.
Anything, the beak is going to remain like this always. See this? This is lamina, this is turbinate, this is beak. Follow the beak, where the beak ends in the frontal. This is never going to change whatsoever, the anatomy is there.
We don't need to open the ostium in every case.
What?
We don't need not reach up to the ostium in frontal sinus in every case.
This is at the level of the ostium only. We are above.
Yeah, we are above, but in every case we need not open it.
So this is, see, the technique can be good only when it is replicable and predictable. It's not the technique is good where which only I can do, nobody can. But it's not replicable and predictable. That means it cannot be a good one. This is so simple. The best part is the landmark I'm using is the most reliable one, the beak. It can never change. Beak is the thickest bone in this region.
Sir, that mucosal bleeding need not be
That
caught,
can
right?
happen. Sometimes, in the region of the beak, sometimes you get the, some veins also. Forget about it.
Need
No,
not
give me.
cauterize.
Yeah. I can, but there is no. If you want, I can show you. I can coagulate also with the monopolar here. So this is
you are
the
using monopolar
venous
curved-
bleeding.
Sir, you are using monopolar curved suction cautery.
Yeah. See this. This is to show you if you want to. Otherwise, better not to do anything. See this? I have stopped. Unnecessarily, don't violate the mucosa. Just pack for a while, it will stop. Now give me reverse. See now, we have seen the frontal sinus here.
Yes, sir.
Our skull base is more than a centimeter behind. So now I will follow this till this posterior table to the level of ethmoidal roof. See this? By the reverse. See this reverse blade. The cutting edges are facing me, protecting the skull base. We call it skull base blade. See both the limits.
Sir,
And now
this will-
see the frontal.
This will
Now
touch
see
the
the
anterior
frontal.
ethmoidal artery, no, sir. This
That
blade
is
will
far
touch.
off. I told you that is far behind and along the skull base. See my beak. The anterethmoidal artery is more than a centimeter behind. So don't terrify yourself.
Okay.
And that is going to be behind here on the skull base. Going through the skull base behind.
So you are superior to that. Anterior, sorry. Anterior.
Reverse. See this frontal sinus, too good. And this kind of, see, the opening of the frontal sinus I'm leaving. This will give the best opportunity to introduce your topical into it. Agreed?
Yes, sir.
Yes, sir.
Now going to be your anterethmoidal artery behind. When you go behind, see this? Back
Yes.
behind. See such a big opening of the frontal.
Yes, sir.
Other thing. Big opening of the frontal. See this?
Yes, sir. Yes, sir.
It is not about sinus ventilation drainage. We have to make it for the future introduction of topicals. Lot of people earlier described that this opening should be this millimeter size, this centimeter size, this, that. Don't fall into that monkey business. This opening should be flushed to the limits. That is the maximum size. You cannot go beyond that to the limits. So no septations are left in between. If you leave the septations in between, can lead to fibrosis and problem. So till limit. See my limit here. Anteriorly limit, laterally limit, medially limit, and posteriorly limit. I cannot widen it beyond that.
Yes.
That's it. Now, this is your anterethmoidal artery. Can you see?
Yes, sir. Yes, sir.
See, from beak here to the anterethmoidal artery there. See how much the distance is.
Yes, yes, yes.
I was working here, and my artery direction is this. So don't worry. Now, give me, once I've seen the vessel, now give me 60. See, don't do anything to this venous bleeding. It will stop. I pack for 2 minutes, this will stop. So don't bother. Now see, there is the vessel. Can you see? Now I am behind the vessel to skeletonize it from both sides. See the vessel, see the vessel. On either side, can you see?
Yes, sir.
If I take a scissors and cut this vessel in the middle, nothing will happen. The problem is on either side. Laterally, if it is transected, can retract into orbit. Medially, where it enters the lateral lamella, the force or injury can lead to defect in the lateral lamella and CSF leak. In the middle, there's a small vessel. If I cut in the middle and it bleeds, nothing is required to be done. Just leave your pack for 2 minutes, whatever in your hand, gel form, Surgicel, Merocel, cotton, whatever, it will stop. See this? This is complete anterethmoidal skull base and the frontal sinus work.
Yes, sir.
Now, last job is the zero. Postethmoid and sphenoid. Now again, fast endoscopic sinus surgery. Camera. Okay. Now see again the roof of the maxilla as your maxillary line. Define your laterally or lamina. See this? See, sometime here you may miss the halar cell. Be careful not to leave any cell blocked. Can you see this cell? Hello?
Yes,
Hello? For your information, can you see this cell?
Yes, yes.
That is what? Just to
Halar
show
cell.
you, halar cell. And what I'll do, yes, I will make this, what is it? Remove this party wall to make it a part of maxillary sinus. Simple. So never, I just wanted to show, I saw notice the small halar cell there. So I wanted to remove this party wall with the maxillary. If it is too big, sometimes you may be mistaken with the maxillary sinus. So read your CT thoroughly, you can avoid that mistake. See this small halar, this is cell, this is sinus, and I am removing this party wall. Okay. So now we have defined our maxilla much better. Okay. Wait. Wash. And now finally the sphenoid and the postethmoid. See, these are the postethmoids. Postethmoid. Entering into postethmoid. Go medially. This is your superior turbinate. See this? Can you see?
Yes, sir.
Go medial to the superior turbinate. See here. I am medial to the superior turbinate here. Now removing superior turbinate. This is my sphenoid sinus. See this? This was a small sphenoid I told you from CT scan. This is the lamella of the superior turbinate which I am removing. And now is to flush everything. Staying anterior to this. See, this is sphenoid. Now
Yes, sir.
all anterior cells you can quickly.
Remove.
This is fast endoscopic sinus surgery. You can be quick and remove all these cells which are anterior to it.
Sir, one blade, how many cases you do, sir?
Ideally, you are not supposed to reuse it.
No. Practical.
See this? These are all septations removed, and that's the final touch now. See, my medial lateral limit all the way is lamina. You have to flush with the lamina. Everything flush with the lamina. Medial limit is your septum. Part of the superior turbinate is left above. The inferior 1/3 of the superior turbinate is resected. Upper 1/3 we never disturb. It has olfactory epithelium medial to it. This is your sphenoid sinus. That's the small, that is skull base, lamina. This is maxillary sinus, this is Heller cell, and this is postsigmoidal cell. That's it. See this full house FESS. You saw in the beginning this patient had massive polyposis. Remember?
Sir, not even 30 minutes, sir. It's 25 minutes. 25 minutes, sir. So by 7, I think you can do the other side also. Yes, sir.
So generally it takes 15 minutes for one side. So any questions for the day before we call it a day?
Sir, we are not ready to call it a day, right?
अरे सुन
We want external
तू
pictures.
रंजीत को करने दे अपोजिट साइड थोड़ा रंजीत जा हेलो
We want
Yes,
external
please.
pictures. External picture we want, sir. Position of
Hello.
the patient. External picture we want, sir.
Oh, actually I've left the case and our colleague is doing now. I came to the console if anybody has any questions. Sorry to
No, sir.
forgot
Tomorrow we will
to show you the external camera setting.
Tomorrow we can see, sir.
Probably tomorrow morning we'll show you. In the first case, I will keep in mind. Anybody has any questions now?
We could see excellent field with adrenal pack only, without injection. Thank you very much, sir.
Tomorrow, besides some interesting situation, we'll show you 1 or 2 drafts. So that will address frontal sinus in detail, you know.
So can you show us the radiological anatomy around the sphenoid sinus? That
Radiological anatomy
around the sphenoid.
around the sphenoid.
Yes, sir. A bit in details.
Okay, I'll show you, not in this case, for in other case. In general, you know.
Yes, sir. In general.
Okay. Let me show you from here. Let me know when you get the picture.
So we are having the picture.
PowerPoint picture. Are you
Yes,
getting?
sir.
Yes,
Yes,
sir.
sir.
Onodi cell picture we are getting.
Yes. See now, this is left side. This is post-ethmoidectomy done. This is medial to it. This is
Sphenoid.
septum, and this is sphenoid sinus pushed inferiorly. Can you see? Now, one of the post-ethmoidal cell is pneumatizing above and beyond the sphenoid sinus laterally. And see, if you keep following the post-ethmoidectomy, that cell, one can easily damage the optic nerve, which is now coming to lie in the lateral wall of the onody rather than the lateral wall of the sphenoid. Because onody has come in between the optic nerve and the sphenoid sinus. Can you see?
Yes, sir.
That's why, irrespective of the onody, in every situation, you must go medial to the septum and open the sphenoid first, and then come widen the, and staying anterior to it, widen the post-ethmoid later. Because in any given situation, that's the level of the sphenoid sinus ostium. In any given situation, optic nerve cannot come anterior to the level of ostium of the sphenoid sinus. Got my point? So, sir, that's an amazing safety point, safety landmark this sphenoid sinus ostium is. If you follow it and don't work in the ethmoids behind the level of the ostium, you can never damage the optic nerve. Now, see this. This is in the lateral section, this section, this is the sphenoid sinus. This is one of the post-ethmoidal cell which has gone above and beyond the sphenoid. And this optic nerve is lying in relation to this cell rather than relation to sphenoid. Got my point? Hello? Hello?
Right, sir.
See this sphenoid sinus again. This is one of the post-ethmoidal cell which has grown above and beyond the sphenoid. And this optic nerve is now coming to lie in the lateral wall of the onody. So be careful. So laterally, this is always lateral. So sometime you see horizontal partition in the sphenoid, the above and lateral is the onody. Okay?
Okay, sir.
Now see, this onody cell going above and beyond the sphenoid. If you take a cut over here, if you take a coronal section over here, it will come like this. The above one is the onody. This is the septation with the sphenoid, and the below one is the sphenoid.
Right, sir.
Okay? So sphenoid is important. See, this is septum, middle turbinate, and in between is the ostium. And inside the sphenoid are lots of tigers running around in the walls with a lot of prominences and depression. We should be able to know that so that we can protect them from injuring into sinus surgery. In center is the sala, below is the clival recess, above is the planum, and posterior superiorly is the carotid artery optic nerve with the recess, lateral carotid optic recess, and medially medial carotid optic recess. See this bone. Most complex bone in the head after the temporal bone. Most difficult bone after the temporal bone because complexity, because of the relationship to the neurovascular structures all around. All the majority of the nerves from the anterior nerves from the brain are passing through lots of foramina in the sphenoid bone. Foramina, this is the body of the sphenoid with two sinuses. This is the lesser wing. I showed you on CT scan. This is the greater wing. Greater wing. These are the pterygoid processes splitting into plates medial and lateral down. This is greater wing. This is lesser wing. In between is the superior orbital fissure. Here from behind, this is the continuation of cavernous sinus anterior. All the cavernous sinus contents pass anterior to the superior orbital fissure in the orbit. All third, fourth, sixth cranial nerves and all that. So this is important to know. This is, and all these foramina, this for through the pterygoid bone, the V2, Vedian canal, through the greater wing. Here you will find laterally the V3, mandibular canal or foramen ovale for the V3. So all these nerves pass to the sphenoid extracranially, and carotid artery is is in close proximity to the lateral wall of the body of the sphenoid on either side. So this is a very, very important bone to understand. See this on a CT, reconstructed CT, that's the clinoid process, that's the impression for the optic nerve, impression for the carotid artery, opticocarotid recess, on either side the pterygoids, and that is the superior orbital fissure. So you see in this picture how what I was trying to say. This is the carotid artery running in the lateral wall of it. That is the optic chiasma on either side above it. And this is greater wing, superior orbital fissure, lesser wing, this foramen, median canal, foramen rotundum, all the same thing in this, diagrammatic view, the same thing you can see, just to orient better. And see what happens. You wanted to know about the sphenoid anatomy. This is how it looks like in CT scan. And once it is over pneumatized, see, this is the pterygoid bone. Once the pneumatization extends into the pterygoid bone at the expense of pterygoid bone, this is lateral recess. That's the lateral recess. That is opticocarotid recess. This is the optic nerve. This is carotid artery impression, and this is opticocarotid recess. So we have to be well versed with the sphenoid anatomy. Pneumatization can be pre-cellar and the post-cellar variety.
So if the keratico-optic, if the lateral recess is well pneumatized, then the foramen rotundum and median canal, are they prone to injury during surgery?
The same thing you're asking. See in this picture.
Right, sir.
This is over pneumatizing. This is your median canal. This is your V2. See there, they are running through the cavity of the sinus. See this, because of the over pneumatization.
Right,
see in the previous one, they are running through the bone. Can you see?
Yes, sir.
This is median canal, this is V2. Here it is over pneumatized. See where is the V2 or where is the median canal? They are exposed. There is nothing there to protect them from the cavity. Okay?
Right, sir.
Then, you have to keep an eye on the septations, the dehiscence of the optic nerve. See, this septa is going to the optic nerve. This optic nerve is dehiscent over here. So all these, anatomy you must go through while walking into the sphenoid sinus. See here, the optic nerve is coming into the cavity of the sphenoid sinus. It's so important to know. Otherwise, if you don't know, one can injure. See the optic nerve passing through the cavity. See the pneumatization lateral to optic nerve. The optic nerve running through the cavity of the sphenoid sinus. Most vulnerable to damage if you are not aware of it. Then, carotid artery. See, there is a thick bone of the carotid, over the carotid, that you need to see. In every case, there is a bone. There is a very thick bone. There is a bone, not very thick, but lamellar bone over it. And here you see very thin bone. Can you see? Thin bone. And now see here, the carotids, there is no bone over it. There's only mucoperiosteum and projecting in the sphenoid. That's so dangerous. We are not aware of it. And any instrument, sharp instrument, can lacerate it on a disaster. See here, one of the septation going onto the carotid artery. If any such septation, if you try to avoid it, it can lacerate the carotid artery. So the principle is to flush them with any sharp instrument, bone punch or drill or whatever, rather than plucking with some instrument which can lacerate the carotid artery. See this, the septation going to the optic nerve. So you have to be careful because anatomy is so variable in every case. In up to 10 to 20% of the cases, the optic carotid are dehiscent, septation is going. It's not so uncommon. The bottom line is working inside the sphenoid has to be fully oriented and fully aware of the anatomy of that particular patient sinus. That's all about the anatomy. You wanted to know about the anatomy of the sphenoid sinus. Anything?
Thank you, sir.
Thank you so much for your attention and enjoy your evening. Thanks once again. Big thanks to the CIPLA for making this event possible. And big thanks to all of you guys for bearing with me. Thank you so much. See you 8 o'clock onwards at dinner. Thank you.
Thank you, sir.
Yes, sir.
Thank you so much, sir. And thank you everyone for joining in. There is an announcement, regarding the tonight's dinner. So everyone would be going. So dinner is not happening here. We have a gala dinner at 360 degree. So it's a bar and a restaurant. So, every doctor would be receiving the cab details and, we would be clubbing all the